All right, we are streaming on YouTube, so just be aware anything we say is now being broadcast on YouTube. And then I will going to go ahead and hit record here, and then in 2 minutes we'll go ahead and I'll push the webinar live. And good luck, everyone. I'll be in the background if anything is needed of me.
Thanks, Tommy.
Yes,
Thank
yes,
you, Tommy.
you all are
And
very welcome.
Zoom Interpreter Control Overview. Instrucciones para interpretación en Zoom. This message repeats in English. Aviso por parte del intérprete. Para hacer uso del servicio de interpretación, favor de desplazarse a la parte inferior de la pantalla de Zoom donde aparecen sus controles, ahí hacer clic en el icono de interpretación, parece un globo terráqueo, y seleccionar Spanish o español. Si está utilizando la aplicación móvil de Zoom, en celular, tableta, etc., presione los puntos suspensivos, luego interpretación y luego el idioma. Announcement from Interpreter. To use the Zoom interpretation feature, please scroll to the bottom of the Zoom screen where your meeting controls are. Click on the interpretation icon, it looks like a little world, and select either English or Spanish. If you are joining using the Zoom mobile app on a cell phone, tablet, or other mobile device, please press the ellipsis, the three dots, then interpretation, and then choose your language.
Good morning. My name is Leroy Blea. I use he and him pronouns, and I'm the Ending the Epidemics Program Manager with the California Department of Public Health Office of AIDS. It's my pleasure to take you through a few welcoming remarks and some logistics and housekeeping comments. Next slide, please. So a little bit about our virtual space today. This is a webinar format in which we have attendee audio and video disabled, but you are able to raise your hand and be recognized and take yourself off mute and ask questions verbally. So there are a couple of sessions later on where you may want to do that. So we're going to remind you of that feature and the ability to take yourself off mute and speak in your own voice. As we just heard, there is interpretation services. So if you are here and you want to talk out your questions in Spanish, please do so. And so those of you that are primarily English speakers can go to the bottom of your screen and check the language preference that includes English or Spanish. And so you'll be able to hear people's questions spoken out in English or translated when folks speak in Spanish today. We also have a question and answer button enabled, so you're able to answer questions and see each other's questions. And we have the anonymous feature enabled. So if you feel more comfortable not sharing your name as you ask questions, please feel free to use that feature. You know, we've been asking some hard questions, and some of our questions don't have the answers now because we don't have complete information. So we'll do the best we can to answer questions within the context of the materials, but and the conference today. If it was not possible to answer your questions, we do want to hear those hard questions. And if we don't know those answers at first, then we will work on coming to getting to those answers. We also allow you to use the chat button. If you have technical issues or having problems with interpretation, please note that in the chat and someone will help you. You have the ability to see each other's chat comments. So use the capacity of Zoom to via the emoji feature and chat to interact with the content and each other. So that we get a chance to actually get to know you and your experience a little bit more. Certainly, we learn as much from you all as you have learned from the content of this symposium. You're all showing up as experts to addressing the syndemic of HIV, hepatitis C, and STIs through a social determinants of health lens. The plan that we are referencing during this symposium was developed in collaboration with community voices. So we will learn as much from you as you learn from us today. And we've also been gratified that people are sharing resources, comments, directly to the Office of AIDS in response to the symposium over the last 2 days. Continue to do that because the resources and the comments are going to be helpful to us contextualizing the materials. We also are developing a resource wall for the Syndemic Symposium, and that will be helpful if you continue to share those resources. This event is being recorded, and the recordings will be available on demand at a later date. We're very gratified to have some wonderful interpreters with us today that are providing translation in Spanish and in English. And so the materials will be available on the permanent website that we build for this symposium in both English and Spanish, including any written materials that we have developed. Some keys for actually helping the interpreters out is to speak slowly and clearly. And if The facilitator may remind you if that's something that, because we all speak quickly, sometimes I do, and I need to be reminded. So we'll remind you if you need to. The key to enjoying the symposium, we feel, is to continue to react to each other and the content through the chat and the emojis. We invite supportive comments as well. So just place anything that your heart and your mind moves you to share, just as personal comments or resources. Don't be concerned with phrasing something perfectly, because certainly this is a perfection-free zone. In this meeting, we are aligning ourselves against HIV stigma, racism, transphobia, sexism, and all other isms. And we will make mistakes, right? When we try hard, we make mistakes in language and in trying to be allies to each other. So if we do make those mistakes, let's call each other into the knowledge of how to do better. And there are a lot of values that we have incorporated into the development of the symposium, and those values are located on page 4 of our integrated plan. And you be the judge of whether we've achieved those values, and certainly we will connect to you again and again through the integrated plan, and we welcome you to use that as a resource going forward. There also is, next slide, please. There also is more detail about the speakers and the content on the website that we created for the Syndemic Symposium. So please feel free to scan this or go to the website that was sent to you in confirmation of your registration. And by the way, we're registered over 500 people now, and that keeps growing, and that's great, because the website is going to be kept up, and we're going to continue to add content to the website that we've built. And then eventually the content will be moved to a permanent web address, and then we'll be able to access the content and the presentations on our website going forward. Next slide, please. We also want to provide a virtual land acknowledgement statement. We acknowledge that this virtual symposium is taking place throughout the unceded territory of California, home to nearly 200 tribal nations. As we begin this event today, we acknowledge and honor the original inhabitants of our various regions in California. And let's take a moment to honor these ancestral grounds that we are collectively gathered upon virtually, and support the resilience and strength that all Indigenous people have shown worldwide. We put the Native Land website, a link into the chat. This platform offers it's a place where users can interact with maps of Indigenous lands, treaties, and languages by entering your address, and you can see where the peoples that reside in the area ancestrally where you're watching our symposium today. Next slide. So it is my pleasure, and actually to begin this introduction, I just want to say that with heartfelt thanks, the Office of AIDS offers to the California Planning Group for helping to develop and co-sponsor this Syndemic Symposium today. The California Planning Group is an amazing group that offers direct feedback to policy and programs at the Office of AIDS. It helps to inform our HRSA Part B planning and implementation. And of course, it connects and has representatives from across all community planning groups, Part A and TGA and eligible metropolitan area planning groups across California. So it has wide representation. Today, we have John Paul Soto, who is the Deputy Director of Lutheran Social Services of Northern California, who is our CPG, one of the CPG community co-chairs. He has over 27 years of experience in social services, in the social services field, including 25 years with Lutheran Social Services of Northern California. As Deputy Director, he oversees all San Francisco-based programs, providing strategic leadership and operational management for initiatives that serve low-income and formerly unhoused residents, many of whom live with chronic health conditions and disabilities. His work centers on the integration of money management, supportive housing services, and is grounded in the belief that housing is healthcare. He is an HIV, John Paul volunteers with the Imperial Council, also of San Francisco, collaborating with local nonprofits to promote housing, health, and safety through fundraising and community engagement. He is one of our community co-chairs, and we're very gratified that he's here to provide a welcome for you today. So John Paul, over to you.
Thank you, Leroy. Good afternoon, everyone, and welcome to day 3 of Ending the Syndemic Symposium Part 4. My name is John Paul Soto, and I'm honored to serve as one of the current community co-chairs of the California Planning Group, alongside my colleague Vivian Gallardo. The CPG is a statewide HIV planning body convened to work collaboratively with the California Office of AIDS. Together, we develop, implement, and revise comprehensive plans that address HIV, STDs, and HCV through surveillance, prevention, care, and treatment, all grounded in the principles of harm reduction. As a body, the CPG is committed to fostering a space where decisions are made openly and collectively, guided by the values of equity, fairness, and respectful engagement. These values are not just words, they are the foundation of how we work, how we lead, and how we show up for our own communities. The focus of today's meeting, Housing First, is a topic that is very near and dear to my daily work. In my 25 plus years with Lutheran Social Services of Northern California, I've had the privilege of walking us alongside individuals and families as they transition from homelessness to stability. We provide supportive housing services to those who have experienced homelessness or have been at the risk of becoming unhoused. I've seen firsthand the transformative power of housing. We are clear that housing is healthcare. When someone has a safe and stable place to live, their physical and mental health improves, their ability to access care and services increases, and their dignity is restored. Housing First is not just a model, it is a commitment to meeting people where they are without preconditions, recognizing that housing is a foundation upon which all other supports can be built. Now I will hand the meeting back over to Leroy. Thank you and have a terrific Thursday, everyone.
John Paul, thank you so much for your comments. And actually, if you have any questions for John Paul, you can drop those in the chat and he'll be happy to talk to you about that. The CPG is, of course, always interested in prospective members, and we can also put the website of the CPG into the chat so that you get a chance to actually interact with the membership, which there are member profiles and information about all the representatives on that body. And of course, you can always reach out to a member of the CPG, in particular John Paul and Vivian, and they can talk to you about what it's like and how to get and how to link to service at the state level on the CPG. Thank you, John Paul. All right, so our first session, to introduce our first session, I'm going to be introducing our next architect of this symposium in general. I would love to introduce Felicia Bard, who is an assistant with the California Department of Public Health Office of AIDS. She represents the Office of AIDS on some key community collaboratives and is responsible for many cross-branch activities. Felicia, I just want to say thank you so much for helping to form this symposium, and you were part of developing its content, and so I'm very grateful to you for that. So over to you to introduce our first speakers today.
Thank you, Leroy, for that warm introduction. It's my greatest pleasure to introduce this next plenary, Harm Reduction Access for People Experiencing Homelessness. Sorry, I lost my notes there for a second. This session highlights the challenges in addressing the various barriers to care, including cluster detection response for unhoused Californians. Our first speaker and moderator is Pike Long. She is a harm reduction specialist at the California Department of Public Health Office of AIDS. For over 20 years, she has been a passionate health advocate and community organizer, focusing on marginalized communities, such as the LGBTQ+ and those experiencing homelessness or incarceration. Throughout her career, Pike has consistently emphasized the critical connection between stable housing and overall health and well-being. Our second speaker for this session is Brett Augstjust. He is currently the Prevention Evaluation and Monitoring Section Chief with the California Department of Public Health Office of AIDS. As the Prevention Evaluation and Monitoring Section Chief, Brett is responsible for the Prevention Program Evaluation, Office of AIDS funded demonstration projects, and currently leads HIV cluster detection and response activities, coordinating with local health jurisdictions to address strategies for intervention. And without further ado, I'll go ahead and turn it over to Pike.
Thank you. Can you all hear me all right?
Yes, great.
Perfect. Thanks. So it's a real honor and a pleasure to be here. I already know a lot of the names and, well, not faces, but a lot of the names I'm seeing in the chat and in the squares. So yeah, this is exciting. We are going to actually have this. I'm going to just do a couple of little slides to set the groundwork, pass it on to Brett, who's going to really dive into some really exciting, interesting data stuff. And then we're going to open the conversation up to everybody else, because as John Paul so beautifully said in the beginning, and I think Leroy mentioned too, we are already in a virtual room full of experts. And so we want to hear your stories, your experiences, and your expertise. And my role, I think, is just to hold the space and kind of help that conversation go well. So without further ado, let's dive in. Could we have the next slide, please? Thanks. So just want to start with a couple of basic definitions. So harm reduction, right? It's an approach to working with people that aims to reduce the harm of a given activity, regardless of whether or not that activity is actually stopped. And in this case, we're largely talking about substance use, but I think it's important to point out that harm reduction can apply to almost every aspect of life that involves any kind of risk, right? So, we all like to use the examples of why we wear a seatbelt when we ride or drive in a car, why we wear sunscreen when we go to the beach, etc. So the other thing I'll say about harm reduction is that it really recognizes that everybody is deserving of care and dignity, regardless of whether or not they use drugs. The second definition we're going to be talking a little more in depth about today is housing first. And again, I know a lot of folks on the call are familiar, but not everyone is. So this is an approach to ending homelessness that provides people with immediate access to permanent housing without preconditions like sobriety or treatment requirements. Housing First recognizes that people require stable housing to get their basic needs met. And just like, again, John Paul said in the intro, it's really hard, if not impossible, to maintain physical and psychological well-being when safe and stable housing is not available to you. So with that, let's move to the following slide. So the reality, of course, is that substance use disorders and homelessness are often intimately connected and mutually reinforcing. We know through groundbreaking research, even from right here in California, that contrary to a lot of the narratives we'll hear in the media, substance use often follows homelessness, not the other way around. Doesn't mean that maybe people never had used, but a lot of the times, in order to survive the conditions of homelessness, people end up starting or expanding their use of drugs when they become homeless. Conversely, when executed carefully, addressing one of these, so addressing housing, can have a positive impact on the other, so substance use disorders. And that's what we want to chat about today. But the fact is right now, our entire nation is living in a housing affordability crisis, which has led to unprecedented numbers of Americans facing housing insecurity. And I think, again, many of us on this call are well aware that a lot of the rhetoric we're hearing is less, in fact, about who these folks are truly and more about a misplacement of blame for how this crisis has become what it is. So I bring it up because I think it's really important to be clear about the difference between symptoms versus the causes of, for lack of I sound grandiose, but I'm saying like social collapse, right? Our systems are not functioning as they should. Federal, state, local policies like the gutting of HUD and supportive housing, the closure of state hospital systems, the lack of a robust medical and social safety net, not in my backyard, NIMBY building and development policies, and the financialization of housing it's a mouthful, have all led to the highest rates of homelessness since the Great Depression. And then as we see in the slide, it's not a coincidence then that, the most vulnerable people often have the least access to care and to services. They are dealing with compounded stigma. So both the stigma of homelessness as well as the stigma of substance use disorders. And so again, like the fact that fatal overdose is the #1 killer of people who are unhoused isn't a surprise, but it also isn't an inevitability. And I want us to talk today about how we could do better on changing those metrics. Let's look at slide 4, please. So, right, why are we talking about housing first? This is a term that's recently become maligned, and yet we're standing by it because you can have housing without treatment, but you cannot have effective treatment without housing. I stand by that. Fight me on it. So this has long been understood and acknowledged regarding HIV via programs like HOPWA, right? So why does HOPWA exist? The Housing Opportunities for People with AIDS, I think I got the acronym right, exists because long ago, people understood that if you want somebody to be able to attend their appointments, stay on their medication, be able to make wise choices that help them maintain their health, they need stable housing. That's why it exists. So why would that be any different for any other medical conditions, including substance use disorders? And we've already seen what happens when you tie housing to treatment engagement, because that is what we've been doing all along with a few small exceptions. So, until 2019, Housing First in California, at least, was really more of a loose idea and suggestion. It was actually made law in 2019. There's a requirement that effectively housing providers, public housing providers cannot discriminate against people for their not engaging in treatment, right? So they can be using drugs and not lose it as long as they are maintaining the other behavioral standards of being in that housing. However, what we've also seen is that it can be really challenging to implement because there is, first of all, a lack of housing of any kind, right? Second of all, there are a lot of loopholes. And then third, there's been a lot of resistance among housing providers. I will drop in the chat a couple of links to our partners over at the California Interagency Council on Homelessness. Those are 2 separate documents there. So, click one, then click the other if you want a little bit more information on Housing First in California and how that can be operationalized. And I just want to acknowledge, though, it is inherently challenging to provide people who are maybe actively in potentially chaotic cycles of use with stable housing. And yet there are a lot of successful programs that have developed really great best practices over the years, and there's a lot we could learn from them. So it can be done. It isn't easy. Let's talk about it. So let's keep going on. Next slide, please. So, all right. Now let's talk a little bit about the barriers to care. We talked a little bit already about the compound stigma. And again, I'll just say, both homelessness and substance use disorders carry massive amounts of stigma in US society. Add to that, the further stigmatized conditions, including HIV, any mental health disorders, a criminal record, maybe immigrant status that might put somebody at risk, being Black or brown in this country, and more. These are all reasons people are already facing discrimination. So when you combine that with substance use and homelessness, it's nearly unimaginable for most of us to conceive of how hard it is to go through a day and be treated with love and respect by most people in this world. So again, it's not a wonder that a lot of people most in need of support are not very willing to reach out for it. So then when we want to think about the extreme disruption caused by constant encampment sweeps, shelter time limits, vehicle impoundments, couch surfing, right? It's really easy to understand how difficult it can be to build and maintain connections with people whose housing situations are not stable. And that's just as treatment providers or care providers. And then the last thing I'll say on this is that even when people are willing and able to engage in care, so whether that be for STI or HIV or Hep C testing and treatment, or whether that be treatment for mental health or substance use disorders, there is a lack of high quality, accessible, affordable, and culturally appropriate settings to bring them to. And that is something that we need to focus on. We have to be able to create those opportunities if we expect people to come in, right? So given all these barriers, how are California providers creating new ways to help people access the care that they deserve? Next slide, please. So, as I said already, I'm really grateful to be in a room full of people working to find new ways to reach people who are most in need of support. So these this means getting creative, right? You all are amazing at being creative. And this includes techniques that harm reduction programs have been doing from the beginning, not to give us, all the cred, but, harm reduction has been pioneering in meeting people where they're at and loving people, having unconditional positive regard from the very beginning. So these techniques include going directly to people via street outreach, hosting pop-up care events, designing low barrier services where people can get multiple needs met in one place, cross-training staff and other care providers, sharing data across organizations to better coordinate care while maintaining privacy. So that's an important caveat. And taking a team-based whole person approach to ensure that people's complex needs are appropriately addressed. So in a minute, I'm going to turn it over to Brett, and he's going to talk about his experience with some of these interventions. And then we want to hear from you about what has worked in your programs. But first, I do just want to say a couple more words about the importance of housing as an impactful health intervention. So next slide, please. So again, this is more about harm reduction in health, but really, again, we know that we meet people where they're at, wherever they're at. So one of the things when I'm talking to people in our consultation phase, so as some of you know, one of my roles is to support the authorization of programs who apply to CDPH to become syringe service providers. In that role, we have to do consultations or get to do consultations with health officers and law enforcement leadership. And one of the things we really like to drive home about why harm reduction is powerful is because harm reduction and syringe programs in particular are really saying to people, hey, we love you, we see you, we are here to serve you exactly as you are, not how we wish you were, right? Do you need a syringe? Come to us. It's safe to share with us that. It's safe to tell us the truth about what you are up to and what you need. There are so few people and places who are that people who use drugs can actually do that with, that again, this is why oftentimes, ironically, harm reduction programs also turn people towards treatment more often than any other intervention. So it's really cool. It centers participant making dignity, decision making. It centers their dignity. It is predicated on respect and autonomy, and builds trust. So again, that's my little love letter to harm reduction. Next slide, please. And then this is something I just wanted to share because one of the most common arguments I encounter, and just, shout out to Los Angeles Department of Health. I totally lifted this graphic from them and then noticed that they in turn lifted it from someone in Spain. So this is like a worldwide stolen graphic. But one of the most common arguments we encounter is that resources spent on harm reduction will be better put toward prevention and treatment. But that is based on a belief in a false binary, right? The harm reduction community needs to get more skilled in explaining the fact that we are not opposed to prevention. We are not opposed to treatment. Absolutely not. Rather, harm reduction services exist to serve the huge number of people who are in that in-between space where prevention has not worked and treatment is not, for some reason or another, currently a viable option. So the way I think about it, harm reduction is really like the bare minimum needed to keep people alive and healthy. As a moral and social obligation, I think it is the least we can do. So another thing that, this presentation that I stole this slide from Los Angeles, they also aptly pointed out that approximately 95% of the people who could benefit from substance use disorder treatment services are, again, for a variety of reasons, not accessing them at a given time. So that is a huge swath of people. And what are some of the reasons why people are not in treatment? What do we know about it? Well, it's expensive. It can be really hard to get into. There can be tons and tons of logistical barriers. It can be really scary. Something a lot of people don't like to talk about is it often is ineffective. I have known people who have, their parents have mortgaged their homes to send them to treatment, and it has not kept them sober, right? So we need to talk realistically about that. And again, I think that the really two-dimensional conversation we hear a lot ignores the fact that many or most people who are in pretty chaotic use have already tried some form of treatment. And for whatever reason, that did not work for them at the time they tried it. So quote unquote relapse is like not only a part of recovery, I would say it is incredibly common and needs to be accounted for. And again, harm reduction is there for the people who quote relapse. Let's go to the next slide, and then I swear I'm going to turn it over to Brett very soon. So I'm not going to talk too much more about SSPs. I think you already know about how valuable they can be, but they do provide safer injection and smoking equipment to people who use drugs. They also provide naloxone and overdose response training, and tons of other resources, including survival supplies, first aid supplies, and more than anything, a lot of love. Next slide, please. Now I'm going to turn it over, finally, to my fabulous colleague, Brett. You want to take it from here?
Yeah, thanks, Pike. I'm excited to be here, excited to be alongside Pike, and excited to talk to you all about three of my favorite topics: harm reduction, syndemic outbreak response, and cluster detection response. So a little just background about me. Again, my name is Brett Juice. My pronouns are he, him. I'm the Prevention, Evaluation, and Monitoring Section Chief with the Office of AIDS. Prior to coming to CDPH, first I should say, I'm just a harm reductionist in my heart. I believe in it. And prior to coming to Office of AIDS, one of my jobs was an evaluator on a HRSA SPINS project, working with trying to build medical homes for people that are homeless, HIV positive, and multiply diagnosed, so have substance abuse or mental health problems. And I got to interview a lot of those folks. And the stories that I heard have really made a lasting impression on me. So I love working with this population, thinking about how we can serve this population better. One of the words that came out earlier was dignity, and I just feel like that's so important when we think about bringing services to people that are experiencing homelessness. Next slide. So it's a little bit surprising that this website is still up in the current regime, but this is Dr. Jonathan Merman, who put out a letter a couple of years ago about how HIV impacts people that are experiencing homelessness. Homelessness and housing instability are linked to higher viral loads and failure to attain or sustain viral suppression among people living with HIV. An increase in homeless and housing instability are associated with increased vulnerability to HIV acquisition. If you've worked with this population, I feel like this is obvious to you, but this is actually a great letter, lots of great resources in that letter. There's a link there. I think I can pop it in the chat for folks. And next slide. I'm just trying to frame our conversation here a little bit with some data. So this is a pretty complicated study. It's a simulation, and it's about population level health effects of continuous sweeps among people experiencing homelessness who inject drugs in US cities. This is a modeling study, and I'll just say all models are wrong. It's just a matter of how much and in what direction. There's probably some nuggets of truth here, though, for sure. So this is a simulation where they used NHBS data to build a cohort and followed it over 10 years. They ran the simulation like 100 times. And what they found is that they had two groups, homeless people that are injecting drugs that are not subject to continuous sweeps, and homeless using drugs who are subject to continuous sweeps. And in the mathematical model, they found that those sweeps contributed to 975 to 2,175 additional overdose deaths. So we're increasing overdose deaths with our sweeps, and increased hospitalizations, fewer initiations of medication for opioid use disorder, and overall contributes to 15 to 24% additional deaths. So think about people that are using drugs and homeless and how high the morbidity is there. Adding continuous sweeps to that equation just increases the health problems for folks that are living homeless. Again, I feel like for people that have worked with this population, that should be obvious, but this is just some data to back it up or to model it. Next slide, please. So this is a case study, and this is unfolding right now in real time. This Penobscot County, Maine, where Bangor, Maine is experiencing an outbreak of HIV among people who inject drugs. On average, from 2019 to 2023, there was one case among PUID in Penobscot County. Since January of 24, up to, I think, almost now, there have been 28 cases. The state of Maine declared an emergency in February of 2024. And then due to community pressure, the SSP in Bangor was closed in March of 2025. This outbreak is ongoing. I expect there may be more coverage of it in mainstream media, but we're going to see what happens when we close an SSP in the middle of an outbreak among people who inject drugs. Next slide. So now I'm going to talk a little bit about the work that we do on cluster detection and response at the Office of AIDS. This work falls under the respond pillar. We try to identify and prevent outbreaks before they happen. And the respond pillar really we need the testing, we need the treatment, we need the prevention, and it feeds back. It's a feedback loop, right? We're reaching out to folks that we think might be part of a cluster or an outbreak to try to bring services to them and identify populations that are underserved. Next slide. So apologies for folks that have seen me do the spiel before, but I wanted to do a little level setting about how we detect HIV clusters. Next slide. There are essentially 4 different ways that we identify clusters. Starting in the upper right there in the purple, we monthly at CDPH, we run an analysis looking for abnormal increases in counties and among subpopulations in counties over the course of the last 12 months. The most common way in the past, I think, has been through partner services or contact tracing, local DIS identifying a network and then notifying their supervisors or notifying the state, and then we provide support. Occasionally, a provider or community-based organization will identify a cluster when a number of folks come in and are testing positive and have sort of the same network. And then the last way is through molecular cluster analysis, which is relatively new for HIV, where we do an analysis of HIV genome sequences and try to identify HIV cases that have similar genomes. Next slide. For today's presentation, I'm just going to focus on the time-space cluster. So each month we do an analysis. We look at each county and subpopulations within the county, and we look for increases of new diagnoses of HIV among people who inject drugs, among females of childbearing age, in the county, but MSM, there are some other categories as well. And we're looking for an increase that's more than 2 standard deviations above a 3-year average. So it's kind of a mathematical process. Last year, we developed an alert for people experiencing homelessness based on housing type at their diagnosis and also current housing. Next slide. So this is a busy slide, so my apologies, but I'm going to walk you through it. This is our program overview. Each month we do our analysis. So if you go down on the left there and think about the process, we update our cluster data. That's the first step. We go to our COCO. That's our leadership coordinating group internally with the Office of AIDS. And if we have things that are of concern, we bring them to our Syndemic stand-up. Our partners in the Syndemic stand-up are the STD control branch, the immunization branch. We work with wound botulism, enterics, harm reduction. Pike's in there with me all the time. Each month, we just come together to talk about, like, what are we hearing? What are we hearing from the field? What are we seeing in our data? Where can we collaborate in outbreak response? And we contact LHJs, we provide technical assistance. We do this on a monthly cadence. So we're pretty busy. And that Syndemic stand-up that I talked about, it's a great meeting. We get together and we just talk about what's happening. And all of this is drawn on our Syndemic approach, the lower right there, our framework and blueprint. Those are linked in the slides. And I think have been linked elsewhere in the symposium. Next slide. I don't want you to get too bogged down in all the numbers here, but this is our cluster summary for 2024. And what I want to point out, one is that we have lots of time-space clusters and molecular clusters around the state. But we started monitoring for increases among people that are experiencing homelessness based on their current address type and also their address type at diagnosis. And we identified 9 counties and 4 regions with alerts in 2024. That's the highlighted in yellow down there. Next slide. When we started doing this analysis, one of the first alerts we identified was a statewide alert for increases among new diagnosis of HIV among people experiencing homelessness at the time of their diagnosis. That increase started in October of 2023. It's since fallen off, but I wanted to use this kind of as a case study, and it was, we did a deep dive into the demographics of the folks that were newly diagnosed and experiencing homelessness. This is an epi curve. It's the last 4 years of data. You can see past the black dotted line. It looks like there's an increase, right? It's a little bit fallen off. It has fallen off of our alert in recent months, but we learned a lot, I think, from this process. Next slide. So I'm going to just run through some demographics of this alert. There were 147 people in the alert, and we compared them to all of the other new diagnoses in the previous 12 months. And what emerged is an epi picture that's slightly different than what we think of as the epi profile of new diagnoses of HIV in the state of California. So you're going to see a series of slides, and the blue is people that have residential housing. So the rest of the folks that were newly diagnosed during this period, compared to the purple, which is the people experiencing homelessness. So they were more likely to be Black or African American and more likely to be white. Next slide. About twice as likely to be female as the rest of the population that contracted HIV during that period, and about twice as likely to be trans women than the rest of the population that was currently housed, or housed at diagnosis, I should say. Next slide. And then the transmission categories were quite different as well. Twice as likely to have unknown risk on the far left there. More an unknown risk, either it was missing or blank. Oftentimes, I think our unknown risk category masks injection drug use, or male-to-male sexual contact, or transgender sexual contact, and it's people not wanting to talk about their sexual practices or their injection drug use because of stigma and all of the things, right? So 3 times as likely to use injection drug use in this group compared to the folks that are residentially housed. Next slide. And then there were also differences in linkage to care and viral suppression, which you would expect, right? About twice as likely not to be linked to care within 1 month. Next slide. And about half as likely or twice as likely not to be. Viral suppression, 25% among people experiencing homelessness compared to 63% of the rest of the population. So a huge disparity. Next slide. So, you know, in our cluster detection and response practice, when we identify alerts, we gather additional information, which we did, and we notify the folks that need to be notified. We notified the Office of AIDS, which I work for, but we convened a meeting and talked about it and talked about possible causes and whatnot. Curious what you all think, but more, I'm curious if there are folks in the room that have collaborated with us on cluster detection and response activities, particularly if you've identified clusters among people experiencing homelessness, or if we've alerted you to clusters among your or increases among people experiencing homelessness. I think we've made a lot of progress in terms of integrating our STD and HIV programs, working in a syndemic fashion. The funding still continues to be siloed, which you can see there on the left. That's just my silos of excellence in terms of our funding. And one of the things that we've done to try to combat that, to try to really do integrated outbreak response, endemic outbreak response, is to just have a regular touch point with each other. All of these folks are at the table, Office of AIDS, Immunization Branch, Infectious Disease Branch, STD Control Branch, and we all get together once a month and talk about what's going on and where we can be of service. And we share information too. Every time I leave that meeting, I think, I'm glad we had that meeting because I learned something about one of the counties or one of the clusters that one of the other programs was able to give me some information on. Next slide. I love to end my talks with this slide because I'm an iterative person. I'm trying to constantly learn and get better at what we do, and I want Office of AIDS, and our last director talked about being the best at getting better. I picked up bread making during the pandemic, and you can see on the bottom there, that was like one of my first loaves of bread, and it was awful. It was gummy and disgusting. And then I changed some things. Making bread is relatively simple. It's just flour, water, and salt. It's about the process. It's about the way they handle it. It's about wanting to make it better and continuously working to make it better. And now on the right there, I still make bread at least once a week. In fact, I need to pull one together this afternoon. My starter's ready, but that's the kind of bread there on the right that I make continuously now. Still trying to get better though. I'm working on baguettes. Anyway, next slide. So let's talk. We have lots of time. If you have questions for either Pike or myself, happy to answer. I'm also curious if there are folks I haven't seen. I see lots of familiar names. If folks have experiences that they'd like to share working with this population. Oh, I'll also say one of the things that happens here at CDPH is the SHIZ call, the STD HIV Information and Support Call, which our Outbreak and Field Investigation Unit collaborates with STD Control Branch on. And it's a call just for DIS to like talk with DIS about how they do their work. And there were a couple of presentations on street medicine in the last 2 months that were just fantastic. I know that there's tons of work happening around the state in terms of bringing street medicine into the STD and HIV space and collaborating with our programs. So I'm curious to hear what's worked, what hasn't worked, anything.
Mm-hmm. And I just want to.
Oh, next slide, please. Yeah,
next slide. Thanks. That's perfect. These are also some prompts that Brett and I came up with for you all in the audience, but I see that we've already got a comment/question from Robert in the chat that really gets right into it, right? I don't know, do we want to, does somebody else who's in this audience want to speak to this? I don't know that Brett or I are experts, but basically, I'll just read it. It says, the new CDC priority statement says, CDC grants will prioritize evidence-based programs and deprioritize programs that fail to achieve adequate outcomes. And again, I take huge issue with this language, just for me personally, Pike, as a human. I don't I don't think this is correct, that fail to achieve adequate outcomes, including so-called harm reduction or safe consumption efforts, that only facilitate illegal drug use. I don't need to read it. I'm sure we've all read it. Basically, though, the federal government wants to defund things that we know work. What do we do about that? What does that mean for California programs? I would love to hear from you all about that.
This is such a hard question. And, it's like, what do you do when all of a sudden you can't trust your partner?
We do have a question from Catherine Tuyoka. So I'm going to go ahead and, Catherine, I'm going to go ahead and allow you to talk. And you're should ask you to unmute.
Oh, thank you.
And we can hear you.
Yay. Hi, Pike. Hi, Brett. So I think what's really important, and I think for the last couple of years, I've kind of been seeing a trend that I think it's important for us on a local health jurisdiction or as a funded level to keep really close track of how we utilize the money and how many people we serve, to have that information to back up what, how the money's spent. It's utilized this way. This is how much we've spent. This is how many people have been trained in doing Narcan resuscitation. This is how many people, this is how many community members, have come to harm reduction meetings, things like that. I think it's really important to keep metrics on that. And I think that's one of the things that if we're not already doing, that we really should be doing, because it's going to be harder and harder to get funding and keep funding. And I think if we can show at least what we can do with the money, that's one way of at least being able to prioritize why we should keep the funding. But I agree, it's really hard. It's hard to quantify, like, how many people, like, how do you quantify how many people were saved by Narcan into a dollar amount? That's impossible.
Yeah, thanks, Catherine. It's like one of the things I always say, you can't prove a negative. And as we all know in public health, like, the evidence of effectiveness is when things are quiet, right? It's like when things are okay, that means that it's working. It's only when there's a crisis that anyone even notices we exist. And so it's really hard to know how to message and sell that, but I don't think it's impossible. Going back, I do see Robert asked a follow-up. I will just say some of the messaging that we have been sharing is that even with the administration's attempts to distance itself from harm reduction, it's interesting because there are still a number of interventions. It actually, for harm reduction programs, it may not change that much in terms of what is funded by the federal government. I do think that the further along we go, unless something happens, it's going to get harder and harder. But like right now, syringes have never been funded by the federal government, nor have pipes. Many harm reduction supplies are not. And here in the state of California, we have the California Harm Reduction Supplies Clearinghouse, which is funded by the legislature and has been for a really long time now. So in that regard, our programs are somewhat insulated in this one venue. The other thing is that in that SAMHSA Dear Colleague letter that was released pretty close after the executive order that Robert is drawing on there, it actually really specifically names that naloxone and fentanyl test strips and MAT services, so medication-assisted treatment, are all still incredibly important. Even they all recognize that it works. They have disingenuously tried to pretend that those were not developed by harm reductionists, because they absolutely were and remain in the venue of harm reduction. But they can call it what they want. The fact is, we know it works, they know it works, and they're not willing to defund that because they know that that they'll lose all support if they do. So it's like it, and then in terms of housing, I can't speak to that. I do think we're going to be in a lot, potentially more trouble, but who knows? I can't say. I know that there are some other questions in that, but there's a lot of comments in the chat too. So I don't know if anyone wants to come off mute and speak more to what Catherine said or what has already been said. Tad's got a comment in here. And then let me see. While you're doing that, I'm going to catch up on the Q&A.
Yeah, Tad, I see your comment, and I know that it's challenging, right? And it's interesting. Some counties have developed systems where they have bolos be on the lookouts, where they're able to share at least some contact information or description with community partners or homeless serving organizations to get around that. There's the whole network of health information exchanges around the state where people can sign up and get ADT or admit discharge transfer alerts from local hospitals and FQHCs if you upload a panel of patients, essentially. So yeah, I mean, and then of course there's just like all the tools in the DIS toolbox, right? In terms of Accurate, going out in the field, going to the places that the encampments and those spots, and
Brett, you have a hand raised too, Jessica Ponce, who can take herself off mute. Jessica, are you able to take yourself off mute? Oh, it looks like that might have been.
Sorry about that. That was an accident.
Oh, okay, no problem. I wanted to comment, Brett, just briefly about the kind of the strategies kind of at the local level used to be, well, harm reduction has always been sort of on a razor's edge of acceptability. And one of the strategies early on was to declare a public health state of emergency, which is not a strategy so much as just summarizing the data and creating an emergency, public health emergency locally that allows public health jurisdictions to supersede local law that at the time outlawed some harm reduction activities. And those were useful because they were a periodic review of the data and updates and to the local municipalities that talked about progress and also tended to summarize the federal reports that showed the evidence behind harm reduction activities and why it was so critical. Some of those processes have become more routine and people have let those go away as we've actually had a space in California that allows for more harm reduction activities. But I'm just wondering if we can potentially go back to a strategy like that, because local health jurisdictions also fund programs on their own with local general fund money because they know that the federal government doesn't support syringes. So it's an opportunity, I think, to think about what we used to do and kind of and then do those things again that were effective and allowed us to change the framework from a criminal model to a public health model for addressing harm reduction activities. Yeah.
Yeah, I think that's a great comment. I'm not sure that I have anything to add.
And I know Pike is Pike. You are a volunteer at a needle exchange close to me, or a syringe exchange close to me, and that's one of the examples of a program funded by general fund dollars, kind of within the city of Berkeley as well. So.
Yeah, and it's interesting because that program receives funding from us at CDPH. That program, which I recuse myself, by the way, from all decisions around it, so I'm not part of that. Conflict of interest is very clear. But also, receives funds from Alameda County. It receives funds from the city of Berkeley, as Leroy said. And private donations. So, right, most programs on the ground have always cobbled together a variety of funds, and I think that can continue regardless of what the federal government chooses to do. Yeah, it's a great point. I know there's a bunch of other, or at least a few other really cool comments and questions. I don't know, Sandra, if you want to come off mute to share yours, or if anyone wants to, but yeah.
Looks like Marilyn has her hand raised.
Oh, okay. Sorry, Marilyn. Go ahead.
Hi, everybody. Can you guys hear me?
Yep.
Okay, great. My name is Marilyn Ramos, and I'm from LA County. I just want to share a little bit about my story just to give you guys a ray of hope and all the hard work that you guys do with this harm reduction. I am a product of that harm reduction Housing First initiative. I really was, homeless and very active in my addiction. When somebody just really believed in me and that I really wanted to change. So they gave me housing. Project New Hope in LA County housed me, and it did take me a few months to get it together, but I ended up going to outpatient program, and I have been sober ever since. And so I now am a peer navigator and a HIV advocate. I am thriving living with HIV, and I have 5 children, and just, my life went on. I'm a case manager. I've been a case manager for almost 10 years. And so your hard efforts and everybody's heart and passion for this cause is absolutely what we need. And sometimes we just need that one hand to stretch out and say, you know what, we believe in you and you can do this. And it really works. It's changed my whole life, and I wouldn't be here if it weren't for that. So thank you so much.
Well, I have tears in my eyes. Marilyn, thank you so much for sharing your story. And that's the thing. I've been doing this for more than 20 years, and I've seen firsthand countless times, right? Like, I know that it works, and there isn't a one size fits all solution for everybody, right? And I think that we are all humans, and we have to recognize people are on their journeys, and we got to support them and love them exactly where they are to help them get to where they want to go. So thank you, Marilyn, for coming off mute and sharing. I really needed to hear that today.
And then we have Sandra, who has her hand raised. I'm going to allow her to talk.
Sandra.
Hi everyone. And thank you for this space to share and speak. Thank you so much to the previous person who commented. It touches my heart, really. My comment around housing and harm reduction and preventing further health, challenges for individuals is in Santa Cruz County. I'm sorry, I'm Sandra from Santa Cruz County. We have been working along with many partners here in this call to eliminate hepatitis C in our community, and it has been truly a uh, beautiful project, but also with a lot of challenges. We have seen folks who do receive temporary housing or shelter in some form. And with the help of a navigator, they're able to cure hepatitis C and engage in other critical services that they need for their well being. So we do see that having housing or in some format, even if it's temporary, having a roof over their heads makes such an incredible impact on their health journeys and their well-being and their ability to engage in the community and society. And personally, the lack of housing programs that support individuals where they are, it's a very frustrating thing and for me in my and professionally as well, because we can treat hep C, there's medications, there's so many other advancements, but housing is critical. And I totally agree with what you're all sharing. Housing is essential for just living, and we lack that. There's that lack, and there's a need, and as a country, as a society, and as a state, we need to do better. That's my comment. Sorry, I don't have more concrete examples to share, but yeah, it feels like we're in great company here. Thank you for the space.
Thank you, Sandra, for sharing.
Just real quickly, Peck, I wanted to highlight one question that you guys had received. The chat's been moving fast, so I just wanted to make sure that we highlighted this. So their question was wanting to hear more about medical housing. They remembered that years ago, the HOPWA program had units, but it seems to have gone away. I'm not sure if that's something that you may be able to touch on, but we may be able to also follow up asynchronously as well on that.
I'm curious if Hillary or anyone from HOPWA is on this call that could speak to that, or really anyone who has experience with this, with housing related directly to HIV services.
I might direct people to the next plenary, where I think Gabriel Maldonado is going to be talking, and I believe that Revolution is a HOPWA provider and has also built housing. And I think that I'm not a HOPWA expert. I sort of have been drawing people from HOPWA into our work, and am often referring local health departments to their HOPWA providers. But those programs aren't usually run by the county. They're often run by like a HUD organization within the county or a CBO. And I think it's there are lots of different experiences around the state, probably, and around the nation. Sometimes I remember in San Francisco, like the wait for HOPWA housing was like 10 years long at one point, and that was over a decade ago. I hope it's not like that anymore, but that housing is a challenging problem, and I think in some ways it's not in the locus of control of public health, but we need it to be more in our locus of control, because as we've been talking about, housing is health. Like, you can't have public health without housing for all.
Hey, Brett, just to comment on that really quickly.
Yeah.
One of the things I think that Gabriel can share with his experience, but when they started developing the EHE plan in the Inland Empire, which includes Riverside and San Bernardino County, they made sure to have their HOPWA representative at the table that helped to talk about what it might mean to sort of build some ending the HIV epidemic strategies that linked to housing. And some of the things that they raised were to become housing ready for a HOPWA unit takes a lot, like the ability of putting people together, their credit score, and all the things that to get onto a unit, it can be difficult. So the concept of housing first needs sort of some more tiers of housing, so that people get not only housing ready, but they get prepared and supported and centered in whatever type of housing that they're ready for at the time. And that concept sounds like you're gatekeeping housing services, but like that, temporary shelter, things that are help with rental assistance and moving costs, the ability, so everything kind of leading up to many different types of units with many types of requirements, right? And also making those requirements less cumbersome for people that housing. But those are some of the things that were discovered in thinking about housing as an ending the epidemic strategy when that plan was developed.
And hi, this is Jessica Heskin with the Office of AIDS. In terms of HOPWA, I looked at your question. It's hard to give a succinct answer because HOPWA, as Leroy stated, is funded different ways, right? Like the state funds 40 counties, but then the bigger counties like Los Angeles, San Francisco, San Diego are funded directly from HUD through different mechanisms. And in terms of the types of facilities I think you were referring to, those are funded through usually in bigger areas. I know Los Angeles used to have some of those facilities. And I think San Francisco did too, but I could be wrong about that. So it kind of depends on how they're funded, and that's usually decided at the local level. But it is true that sometimes we have to make decisions, on how we want the funding spent and leveraging it against other dollars as well. So the one good thing is that most of our HOPWA, all of our HOPWA counties are actually also Ryan White funded. And so sometimes they can leverage back and forth in terms of case management and that type of thing. But if I had more specifics, and if you feel free to email me, I'll put my email in the chat if you have HOPWA questions, and either I can answer them or I can pass them on to our HOPWA team. Oh, Felicia, right on it. Look at that. There's my email. That's probably good because I would have misspelled my email probably. I'm notorious for that. Thank you, Felicia.
Thanks, Jessica, for speaking to that. I know that Kevin had a question quite a while back, and I wanted to, again, I hate to keep turning it around on the audience, but or anyone, please chime in. Can you share any stories about people you've worked with, either in harm reduction or cluster detection, who became advocates for your work, helping to get others to work with you? I don't know if anyone here would like to share any stories of that happening.
I think we heard one a moment ago from Marilyn. And again, thank you for sharing your story. I needed to hear it too.
Yeah.
But if there are others, I'm happy to hear it. And for my part, my primary customer or consumer is not the end user, it's the counties. So the folks that I'm working most directly with are the counties. And if there are any of our county partners that have worked with me or with us on cluster detection response that want to speak to that, I would love to hear your voices as well.
Brett, while you're waiting for that, and Pike, I was just wondering, the community advisory board that you have for cluster detection response in collaboration with San Francisco and Los Angeles, talking a little bit about that, has that changed the way the state has approached CDR work, like that input and individuals from that? And I think there's a beautiful website that LA puts up that where you can interact with all of the profiles of the people that are on the community advisory board. But if you could say more about that.
Yeah, I mean, we have a great community advisory board for cluster detection response. There's 16 members from around the state. They have provided us feedback, and I think I did a terrible job today, probably, of using more accessible language to talk about cluster detection response. They provide us feedback on our language. They provided us feedback on some of the evaluation that we do on this project, and they've become incredible advocates for this work. And I'll see if I can grab the article that was recently published about cluster detection and response in Adelante. Yeah, thank you for that question, Leroy. I'll grab that link.
And also, it looks like Kevin has his hand raised, so he'll be invited to unmute in just a moment.
Can you hear me now?
Yes.
Okay, cool. Thank you so much. Your work is some of the challenging work because a lot of people might defend themselves and their communities against the sex police. And yet at the same time, an example that I had once was someone who was not going to share anything, even though he talked about having a regular sex party that he went to. But he wasn't going to give any names or anything. And when we talked about how the privacy and the fact that his name would never be involved with their name, if he was swinging from a chandelier when he did it, they wouldn't be told that. So just that anonymity and also the benefits of stopping spreading the infection. Once he was able to hear the safety and trust of partner services, he was able to share, and they actually had a partner services person come to the party and work with people before the party began. So, and after that, they were very much into pro partner services. So I think that we can try to find our peer advocates and start to appreciate that it's not sex police as much as sexual health providers.
Kevin,
Same
I am
values.
so glad to hear you say that, because that was exactly, I was like, once again, like peer leadership, really hiring, paying, consulting with, and having people from the communities of folks most impacted again and again is the solution, right? That is who people trust. You have to have a trusted messenger, or you'll never be able to get in there with people. So thank you for uplifting that, because yeah, it's important to build those relationships and treat people like, they have autonomy and dignity. And of course you understand where they're coming from. Nobody wants to be have their most private, intimate sexual details in a public database, really, Yeah.
And then we have a hand raised from Catherine. I'm going to go ahead and allow you to talk and ask you to unmute.
I'm sorry, I had to take a call, so I apologize if this is a duplicate of what someone might have already said. But I wanted to let you guys know that San Francisco UCSF has that Deliver van, which is run by a transplant hepatologist, Dr. Price, and they go out into the communities. They're in front of SROs in San Francisco, getting people liver diagnosis, and they've got fiber scans on board to even assess if they're possible for if they're so bad, if they need to have a transplant. They're able to bring that information out to the public. And some of you in the community might know of Polly, who's been in San Francisco as an advocate for a long time, and he's recently, for the last year, been hired on as one of their peer outreach educators who goes out and so it's the Deliver van, and I'll put it in the chat. So Polly, who's basically an ambassador in San Francisco for a lot of the people who are kind of their daily life might be a little chaotic, and he's got a dog, and he has worked a lot in substance use disorder and and hep C, and so he's one of like the ambassadors who brings people directly to the site. And he along will train other ambassadors to work with people on the Deliver van so that they can at least get medication and treatment and cure, because they're so effective in San Francisco. So he was someone who I think was treated and then now has been hired on.
Thank you for sharing that story. I think we see Polly getting a lot of love in the chat. Those of us who've had the pleasure of knowing him over the years is, yeah, what a delight. It's been a long time since I've seen Polly. Well, I know that it's 1:17 and this session ends very shortly. Does anyone have any final questions or comments? You all have been incredible so far. But before we bid you farewell for this session, it sounds like the next session is the perfect one to land in, though, specifically talking again about housing. That in silence. I'm going to be quiet. More wisdom from Marilyn in the chat. Marilyn, did you want to come off mute and read what you wrote? You don't have to, but I really appreciate it.
Hi all. I just shared in the chat to please consider hiring people with lived experience, whether that be living with HIV, substance use, or homelessness. It makes us such a huge difference. And we did have a peer program that lasted about 18 months, and unfortunately we got shut down February 2025. But I continue to stay in contact with the women that, we created a community and just this sisterhood and just bond. I have one of the participants that was living in Skid Row when I met her, and she was really active in her addiction, was housed recently, and she's doing really well. She went back to school. She's been sober for 6 months. She recently attended the Christie's Place Dancing with Hope retreat, and I just really see her doing really well and being a fierce advocate in the near future. So it really, really, she told me when we were driving back from the retreat that it really helped her, how she would be able to call me and tell me, like, I used today and not feel judged. And so, for the people that are there for us when we do have a trip up or a slip up or whatever you want to call it, it makes a big difference just to hear us out and allow us to feel normal. Like, it's okay to, have a slip up or just use a day and then pick up tomorrow where we left off. So yeah, I just wanted to share that. Thank you.
Thanks so much again. Well, on those wise words, I think we can wrap up this session. Huge thanks again to everybody for sharing your wisdom, your experiences, your questions. And if you have any comments, questions, feedback for Brett and myself, our emails are right there on the screen. And I look forward to continuing to work with you all. We really, really deeply appreciate what each and every one of you are doing to keep people safer across California. All right, have a wonderful rest of your afternoon, everybody. Thank you.
Great. Now we can go to our break slide. Next slide. And we'll be back at 1:30. Waiting for that countdown. And also, we want to welcome you back in just about 30 seconds. All right, welcome back. My name is Leroy Blea. I'm the Ending the Epidemics Program Manager with the California Department of Public Health Office of AIDS again, and I use he, him, and his pronouns. And I just want to give a lot of appreciation for that last session on harm reduction and housing first. It was an amazing dialogue of connecting harm reduction for just making those services not an issue for people experiencing homelessness, that they can access those services, and how vital those services are, particularly in the interaction between housing and healthcare. So amazing. If you could give some flowers for the panel, that the two presenters, and also the people that provided some amazing testimony and questions as part of their experience. So thank you all. Next slide, please. So let me set up this presentation a little bit, because this is entitled CBO Strategies for Supporting Sustainable HIV, STI, and Hepatitis C Work. And we have three amazing leaders with us today that I'll introduce in a second, but I wanted to just let you know, as we were thinking about this session, it's on day 3. It's an opportunity to do some integrating of the 3 themes of our Syndemic Symposium, which has been stigma-free services, economic justice, and now housing first today. And we have 3 organizations that are very different, and 3 amazing leaders that head those organizations. And I think that they'll all tell you how their mission and their vision also is firmly embedded in community and the populations that they serve. That's one of the common themes among these 3 leaders. And actually, that's not just these 3 leaders. I want to say that if you're a CEO, or if you're an executive director in the room, we also want to hear your voice as well. We felt like we needed a session talking about sustainability of this work, given that the funding and policy environment has shifted so radically. And one of the objectives, or some of the objectives of this session, are to talk about the successes and challenges and next steps about supporting the economic viability of these organizations. And even before this year, things can and may have been getting tough for aid service organizations and community-based organizations that do HIV, STI, and hepatitis C work. So we want to hear about those stories and some of the strategies that people have been able to get around to actually developing models to address those things. And I have had separate conversations with Rhea, with Jake, and Gabriel over the course of the last year about these various topics. And I felt like, wow, this is perfect, because this is the 3 people that are thinking about this in a very active way. So it's my pleasure to introduce our 3 speakers today. First, Rhea Van Brocklen, who's the Executive Director of Christie's Place. With over 23 years of experience in the HIV field, Ms. Van Brocklen has developed and implemented and evaluated numerous HIV prevention and care programs under CDC, HRSA, and SAMHSA funding, and also state and local funding. In May of 2019, Ms. Van Brocklen became the Executive Director of Christie's Place, and has deepened her passion of empowering San Diego women and families living with HIV to achieve their best lives possible. And in a minute, we're going to be asking each of these leaders to introduce themselves in a little bit more detail. So I'm just going to give you a preview. Jake Bradley Rowe is the Executive Director of Sunburst Projects. Jake is in Sacramento. It's the Sunburst Projects is a nonprofit dedicated to supporting individuals and families impacted by HIV and AIDS. With over 2 decades of experience in nonprofit leadership and fund development, Jake has guided Sunburst Projects in expanding services, strengthening partnerships, and advancing health equity across the region. So we have Jake with us today. Welcome. And also Gabe Maldonado, who is the Chief Executive Officer of True Evolution. Welcome, Gabe. He is an activist, a longtime community organizer, founder, and the Chief Executive Officer of True Evolution, which was founded in 2007. True Evolution is a health and justice organization serving LGBTQI youth, seniors, and people living with HIV in San Bernardino and Riverside counties. And just to set this session up more, these are 3 very different organizations as well that have different strategies for addressing the syndemic in California. So I'm going to invite our 3 speakers to introduce themselves in more detail, contextualizing their introduction and the work that they do with their organization in round robin as we begin this dialogue. So Rhea, we're going to start with you.
Okay, thanks, Leroy. Hi, everybody. It's great to be here. I'm very honored to be part of this panel with 2 other amazing leaders in the field of HIV. Christie's Place, we are a small grassroots nonprofit organization based in San Diego, And our mission is to empower women, children, and families who are impacted by HIV to take charge of their health and wellness. We're going to be celebrating our 30th anniversary next year. So we've been in the community for a very long time. And like Leroy said, you know, I feel very honored to be part of this panel and I'm looking forward to the conversation. I'll pass it on to Jake.
Well, good afternoon, everyone. As they said, my name is Jake Bradley Rowe, and I'm proud to serve as the Executive Director of Sunburst Projects. We're a nonprofit organization based here in Sacramento, and we've been working and serving the HIV community for about 35 years. Sunburst Projects started as a summer camp for kids living with HIV and AIDS, and over the decade, we've evolved into a nationally recognized organization providing comprehensive client-centered services. Our mission is pretty simple, but very powerful. We're to improve the lives of people lived with HIV, prevent new infections, and ensure that everyone has access to care, education, and resources without barriers, stigma, or judgment. In the last 5 years that I've been here at Sunburst, we've grown significantly. We've diversified our funding and launched quite a few new innovative programs, which we'll talk a little bit about today, including our Sunburst Clinic, which is a free walk-in HIV testing clinic here in the Sacramento area that focuses on serving high-risk and underserved populations. Our primary program is funded through the Ryan White CARES Act, and that is to support clients holistically by addressing not only their medical needs, but mental health, housing, and social services as well. I think what makes Sunburst unique is our commitment to accessibility, inclusivity, and cultural humility. We hire from the community we serve, we employ bilingual staff, and we ensure that all clients are seen, respected, and empowered. I'm really excited to be here and share more about what we do at Sunburst Projects, a community hub that's a source of support and a driver of public health innovation here. Thanks for having me.
Welcome, welcome. Gabe, over to you.
Yeah. Well, good afternoon, everyone. Gabe Maldonado, joining you all from Los Angeles today. I'm at the historic Carl Bean House. If anyone doesn't know Carl Bean, you must visit the historic Carl Bean House. True Evolution was founded 18 years ago now. I founded the organization in 2007 at the height of the Proposition 8 campaign. And over the last 10 years, we've grown into being from an advocacy organization and an education-focused org into a direct service provider. So all of the infectious and communicable disease response from monkeypox to COVID to HIV and STDs. And then in the last 6 years, we've moved into housing development. We were originally housing opportunities for people with AIDS, HOPL providers. And in the last 5 years, we've sort of diversified our portfolio to now be in the production of new housing. And so that is a big part of what we do. We are room key recipients. We are home key recipients, if anyone's familiar. We are Ryan White Part A, B, and now C as of this morning. So we just got Ryan White Part C. And so the big part of what we do is looking at an integrated health model where we pull together healthcare, housing development, workforce, wellness. And so all of that is currently piloted on our Project Legacy campus, which is our first integrated housing, mental health, and healthcare facility. And then in January, we launch our medical center. So open enrollment will begin November 1st. And we have 2 providers that will begin medical services at the top of January. And there will be a focus on HIV and infectious diseases as an entry point to care.
Wonderful. Thank you all for that introduction, and congratulations, Gabe, and the new funding.
Thank you.
So we have a couple things. This is Oprah-style talk show for this session. And what we like to do is to pose questions to the panelists. And we have a single question that we prepared to ask each panelist, and we have some other questions. But we also wanted to pose a question to you all in the audience. So in the chat, I posted the question, what are some of the challenges and opportunities that HIV/AIDS service organizations, and actually to include the HIV/AIDS hepatitis C and STI service organizations currently face? And feel free to put those stories in the chat and maybe kind of queue up other questions that you'd like to ask this panel. But we do have a round robin here, so I'm going to be asking Rhea, you the first question. And the question is, how do you continue to center your mission in your sustainability planning? So given the fact that, and actually if you could talk a little bit about some of the things that you talked about to me directly when you were thinking about sort of doing sustainability planning. And then we were at a community meeting, Ray, and one of the things that you said was that, wow, we really need to think differently about our work. And if we're not, then we're going to be in trouble. So if you could contextualize sort of that question with that as well.
Absolutely. Yeah, happy to do that. So Christie's Place, we are one of the last remaining grassroots aid service organizations specifically serving women and families left in the country. A lot of other grassroots women serving organizations have been either acquired or merged with a lot of clinical spaces. And what I found about this organization in the 6.5 years that I've been there is that we are stubbornly non-clinical. And so when I really thought about sustainability, I was fortunate enough to be in business school and got my MBA this year. And there was a term that continued to kind of deepen itself in my head of this this thing called a beachhead market. And this is when there's a really concentrated, very clearly defined focus of an organization or a mission or a business. And I really think that's where Christie's Place excels. And I think being a beachhead market and focusing specifically on a very targeted population, as well as understanding like what we do well and how we complement versus duplicate services with some of the larger service organizations here in San Diego. That's kind of how we found our seat at the table and continue to do so. And so the mission is very much centered in all of our work, in all of our programming, the way that we look at fundraising, and it is to serve that targeted community. And we've expanded it a bit over the years. You know, we're serving not just women living with HIV, but now we're also expanding into prevention work. And our definition of women is very much the community's definition of women. So we open our doors to our transgender folks, our gender non-binary. And so we do still seek to expand our understanding of who we're serving. But I think having that beachhead market focus helps us to not duplicate services that are already well established among other providers here in San Diego. And it's a very crowded funding environment right now, as I'm sure many of us are experiencing that pinch. So having a very strong foothold on what we do well and what we do best has allowed us to kind of go deeper into the community. And it also is a demonstrated validated model, you know, so our focus on empowerment training for people living with HIV, of really helping our women tell their story, and that can lead to advocacy efforts, storytelling efforts. These are best practices that we know have gotten women closer to viral suppression and engagement in care. And also, like, having that perspective of going deeper into the community rather than spreading ourselves thin has also helped us to maintain sustainability of a lot of our programming and even expand them into other areas that maybe have seen the value of our work and thought to themselves, you know, how can we do this in LA? How can we do this in Palm Springs among women that live there and maybe could benefit from these types of services? So I think too, part of our responsibility as leaders is really maintaining that focus and avoiding mission drift, which can seem very doable in this day and age where maybe funding isn't as easy to grasp as it has been in the past. But I think the more focus that you do on your mission and really commit to the populations that you serve, at least for us, it's worked out really well. And luckily, we live in an area where it is pretty resource rich, and we build upon our collaborations and our partnerships, knowing what we can bring to the table, and again, not duplicating what's already in existence and already there. I also think that, you know, positioning ourselves as a beachhead market helps us to anchor some of the work that's been identified as important in San Diego's ending the epidemic, getting to zero landscape. We know that women often are the ones who seek care last. So providing a space where they can learn how to put themselves first and to teach those same type of values to their community, to their family, that what you see then is a generational trickle of really positive health and wellness ideas and things that take root that won't affect just the person living with HIV, but their family and their community as well. So hopefully that answers how we stay mission focused, but I feel very privileged to do what we do.
I love the phrase you use, stubbornly non-clinical, meaning that you're centered in the mission and the things that you have created within Christie's Place that fill a gap. And that needed gap is being filled, and it sounds it is an actually I've had the honor to visit Christie's Place as well, and you can feel it when you walk in the door. So it's an amazing thing that the organization has been able to build there. And there's history on the wall and history all around when you walk through Christie's Place.
Thank you. Yeah, I love it there. I told myself I was never going to be an ED again when I moved to San Diego, and all it took was me walking through those doors to change my mind. It really is a very special place. And again, one that I think deserves to be kept and cherished and continue to impact our community in the best ways possible. So thank you.
Amazing. And actually, I'll just put this out to the audience too. If you have ever thought about being an executive director and maybe you don't see the steps that it would take to actually get there, that this is a great group of people to ask questions about what are those next best steps to actually preparing you for leadership and a community-based organization, or maybe even creating a community-based organization of your own. So think about taking yourself off mute and talking about that. Also, we're going to invite the panelists to kind of interact with each other and talk, so you can respond to each other's questions as well. So feel free to do that. Jake, the next question comes to you. And the question that we have is, how has collaboration and work with partners been important to your sustained efforts? So please tell us a little bit about that and anything else that might help us contextualize that question.
Well, sure. Well, I think maybe it's important to give a little bit background of myself. So 5 years ago, when I came to Sunburst, prior to that, my career had been in the for-profit world. I was a national sales director for an organization. So sales kind of comes naturally to me, and networking and partnership. And so when we think about collaboration, this was really what immediately came to my mind. Collaboration isn't just important to the work we do at Sunburst. It's absolutely essential, right? It's how we maintain and we go forward. When I came to the organization, it was at a crossroads. It was really at a spot, rather, could it keep going or not? And I knew that in order to keep serving the community that we were working with, we couldn't do it alone. We had to build resources, we had to build capacity. And so collaboration was that way forward. And working with a diverse set of partners has allowed us to expand our reach, innovate programming, and meet our clients where they are. These partners are healthcare providers, nonprofit organizations, government agencies, community leaders, and even corporate partners, which is where I was able to really tap into. Together, we've built and create systems that ensure that our clients not only get tested for HIV and STIs, but they're also linked to treatment and prevention and social services seamlessly. Each partner that we've reached out to and created a relationship brings something unique to the table: expertise, access to populations, technical resources, and even operational support. By combining our strengths in those partnerships, we've been able to achieve outcomes that I just don't think we would have been able to on our own. But I'd like to really highlight something that often is overlooked in collaboration, and that is the role of funding partnerships and how we strategically braid those resources together to build sustainable programs. Here at Sunburst and in the nonprofit world, and particularly in public health, funding is often fragmented, right? We see grants that are released and they have support for just certain services, or they're very time limited. And they often come with very specifics around how we report or what the outcomes must be. Early on, when I started looking at our programs here at Sunburst, how are they going to truly work and last? I needed to be creative by leveraging multiple funding sources together. I wanted to make sure that the positions that I hired had longevity and they had stability behind them. So when I brought someone into this organization, there wasn't fear that when a grant went away, their position went away. So braiding funding really is about taking the resources from different funders, whether they're federal, state, local, or private, and intentionally layering them on each other to complement one another, rather than compete with each other. It allows us to fill gaps and expand services, create continuity for our clients. For example, a federal grant may cover testing, and a state grant may fund behavioral health services. A private grant might fund outreach and community education. By combining these sources strategically, we were able to build holistic programs here that address the medical, the behavioral, and the social needs of the clients in a very cohesive way. This approach requires deep collaboration, though, as you can see when you're looking at federal, state, and local partners. But we work closely with the funders and we show them how their investment, when braided with others, amplifies the impact and sustains outcomes in a long-term approach. It's a partnership model that emphasizes accountability and data-informed strategies and measurable results. I think often as an administrator, I think I don't really want my partners to know the value that the others bring because I'm worried that they may be concerned that we're overfunded or that the program's well supported. But I think if we provide data-informed strategies and measurable results, we can really prove that the demand, and we all know the demand to ending this epidemic is far and great, that all of it is needed. So our ability to demonstrate the impact attracts not only new partners and funders, but it continues to provide a virtuous cycle of collaboration, innovation, and sustainability. Let me give you an example of what that looks like here. So I mentioned earlier in my first introduction, the Sunburst Clinic, which is our free walk-in HIV testing site. Through partnerships and braided funding, we were able to design a clinic that not only is barrier-free, but also is culturally competent and client-centered. We employed bilingual staff, we hire from the community we serve, we provide mental health to those who test positive for HIV on the spot. We facilitate warm handoffs to prescribers who get clients started on rapid ART immediately. And those who test negative, we also provide access to PrEP and PEP. But that's all done in one place. And that's because we were able to take multiple partners and the funding and the support and the relationships we built with them and layer them upon each other, braiding those relationships together. In the end, collaboration and braiding funding, really, it goes hand in hand. By working closely with our funders and partners, we're able to stretch every dollar further, create innovative programs, and really respond to the real needs of the community, ensuring that the impact we make is not fleeting but lasting. Collaboration allows us to dream bigger. Braiding funding ensures that those dreams can be realized with concrete and measurable results. So when I think about why our efforts have sustained over time, it comes down to this. We aren't working alone. We're not reinventing the wheel. We're utilizing everyone that's within our reach to make sure that we have them. We build partnerships and we share knowledge. We innovate together and we weave together those resources in a way that creates this holistic solution for our community. And I believe that's the only way that we're going to move the needle forward in HIV prevention, care, and equity, not just for today, but for years to come. So I would say that if you as an organization, whether you're a nonprofit or you're a federally qualified health center, aren't reaching to those community partners that are around you, I would really start putting some effort into that. Again, don't recreate the wheel when it's already there for you.
Hey, thanks so much for that response. And there was a lot in that response. And I'm thinking of, I think one of the things that we had as a first conversation kind of building up to this was this concept of braiding of funding. And you told the story of kind of like the vital connection of that's part of sustainability, making sure that things are overlapping and there's some challenges there. And so it sounds like you're a great place to go to ask about the technical aspects of that within the concept of multiple funding sources that may have competing interests potentially, but not necessarily if you kind of build a program that has various aspects of these funding sources. So we invite actually folks to link to these leaders about those. I think that the wonderful thing about California is that there's so many wonderful leaders that that this is a community of practice where they can kind of lean on you and each other. And so thanks so much for Rhea, for Jake and Gabriel for putting themselves out as part of that community of practice here. And I know that people reach out to you to ask, how was this done? So The next question, Gabe, is going to you, and this is sort of a narrative I think that has been important to, or this is a question that has been important to True Evolution, and the question is, how has advocacy, budget, and policy advocacy been connected to your progress and success at True Evolution? And I'll contextualize this further by saying that we've been getting a lot of feedback that it's important for us as a community of practice to get the right information to the right people in the right way to sort of influence the environment, the policy and funding environment around us. And I think that you have an amazing narrative about how True Evolution has been able to do that. So if you could share your story about that
Sure.
as that first question.
Well, so firstly, True Evolution is located in a county that voted yes to Proposition 8 by 68%. We are one of the reddest districts in the state of California. I mean, I wouldn't name all the officials, but if I named all the officials I could name, it would horrify you as who my officials personally are. Some of them are. And so from our very inception, we have had to make politics, community building, advocacy, working and creating coalition, not only with people who are aligned stakeholders, but non-aligned stakeholders as well. And so that has resulted in us being able to secure various rounds of funding through advocacy work. And so we did receive $10 million and then subsequently $3.063 million in advocated assembly budget funding. And what I would say is one of the benefits that I've seen in the diversification of our funding is that when we moved into housing development and community development is a completely different universe. Like, I mean, had I known this, I would have started there and then backwards into public health. And it's only because the increments of dollars and the sort of political receptiveness of building and transforming underdeveloped communities has a very different cachet to it. There are different increments you apply for when you get into that world. You start to identify a whole range of funders that you had no idea were actually interested in development, the energy sector, the transportation sector. There's all these other sectors that us as public health people, we're always reaching to the pharmaceutical industry and bioscience and biotech, but there's an entire corporate apparatus that is connected to housing and community development, specifically the building of new housing. And so I think being able to use that advocacy narrative of housing people who are homeless, building areas that are rural, doing neighborhood revitalization projects in areas that may need revitalizing, that and being able to tell that story creates a tip of the spear that allows you to then bring in other elements of your programming like HIV, like mental health, like core primary care services, like workforce development. And so, involving ourselves in advocacy and policy has been very helpful. What I would just back up and say briefly about, people who want to do this work, particularly as CEOs and executive directors, Rhea said something that I connected to is that I also have an MBA as well, and I'm doing my PhD in business right now. So I hope to teach it one day. And part of, for me, the importance of business is not just the academic mechanics of that we've learned, right? It's not just that we know how to do pro formas, we can read balance sheets, we understand certain, fee schedules. But business really teaches you to look at everything in terms of revenue drivers. Everything, like everything. This table is a revenue driver. Somehow I need to make money off of this table. And your brain orients that way. And so what I would encourage any of my colleagues who want to get involved in entrepreneurship in any way, whether you're a founder or whether you bravely take up the role of another organization, which is its own level of courage, right? Because as a founder, I have a lot of control. And so whatever your approach is, having that mindset where we are no longer shaking the tin can anymore, people, and they are not dropping coins in it anymore. And so now our minds have to reorganize itself. And if you want to use an example, I use Homeboy Industries as a case study often. They were founded in 1986. by Father Boyle, and now they have a $40 million budget, and 25% of that budget is made up of social enterprises. And so this is non-grant dependent, non-contract dependent money that they generate. And I would encourage all of us to look at our own slices of the universe and see where we can identify drivers of money in everyday commonplace business. And Homeboy Industries is a great example of how they do both impact and profit at the same time.
That's a great response, Gabe. And since you brought us to this point where like preparation and how you prepared yourself for that. And Ray, you talked a little bit about your MBA. Is there anything else that you did to prepare yourself to step into this leadership role? Gabe also mentioned this difference between a founder and then someone coming in and into an organization that someone else has started. Maybe if you can talk a little bit about how you came in.
Different skills needed. Yeah, Ray.
Yeah, no, I think I actually wrote part of my capstone on Homeboy Industries, Gabe. So it's really kind of cool that you brought them up. No,
Yeah.
I think you're absolutely right. You know, as a leader, you really have to look outside the box and what's been previously tried in order to continue to sustain and grow your organization. And part of that is being really strategic and also brave and piloting things that, you know, it may not have been done before, but my theory is if you don't try it, you don't know, right? And so have a board behind you that can support that type of courage that it takes to run an organization, especially in this day and age, and especially within the field that we're in, right? I think too that having that business acumen is often not seen enough in the nonprofit world. And that was one of my comments when I was finishing up my program is, you know, there should be outreach to nonprofit leaders so that they can enter this type of education and experience because it's only going to benefit them in the long run, where you have to look at things from an entrepreneurial lens and try things that maybe are uncomfortable, but your mind shifts from being something that's waiting for money to come to you into being something that, you know, these are opportunities that we need to seize, and we need to build and strategize ways that our organization can support those types of opportunities. So already, like at Christie's Place, I think part of it too is just really understanding your work and what you're very good at. And when you're in a situation where maybe there's not as many organizations that do similar work, it's important to be kind of a catch-all and to provide services in the way that's most accessible and easiest for our folks to access. So in other situations where maybe there's a lot of places that are competing for the same resources, find your seat at the table and what makes you indispensable to these other programs. And then also just find a way to capitalize that and continue to build upon, you know, those partnerships that Jake talked about. Having great relationships, I think, as a leader is absolutely important. And you can't do any work if you piss everybody off. So finding a way to like really partner well and partner strategically and share those resources, that too, I think will really help folks get into the mindset of running an organization.
Amazing.
Yeah, I would also say that business school certainly helps you find the network of future donors. I will tell you that. So that is also another benefit. But even if those that do not want to go to school to formally learn business, it is important to take up mentorship, to identify accelerators. To look for executive certification programs, because there are core fundamentals that before the nonprofit sector allowed us to be able to operate our business off of charity. So the charity we received was enough to do business. My insurance products to run my business have gone up by 30% this year. So that's general liability insurance. These are like things that are like not sexy items that a funder wants to fund. Like just the cost of doing business is very expensive. And so for those that want to be founders, I would say to identify an extremely niche area and let that grow. And that's because these broad-based community orgs, we say, you know, I serve Black people in LA. Well, baby, there's a lot of people serving Black people in LA, and some people do it better than you. So you just need to be careful if you're wanting to develop an innovative, self-sustaining business model, that in this day and age, the cost of entry, the barrier to entry is very, very high for many businesses. And I would almost encourage what Rhea has done, and I think that we need the matriculation of more experienced business-minded leaders to come into existing institutions so that we can transform and grow them into the next level. So what Rhea did is really what I would champion more people to do. Trust me, you don't want to be a founder in 2025.
Thank you so much, Gabe.
Yeah.
Actually, we're going to go to Jake and with the same question, really, kind of the preparation that it took and kind of the mindset to come into leadership in your organization.
Yeah. Well, I took over Sunburst 2 weeks before COVID. Never worked for a nonprofit ever. I was coming from $500 million budgets to a $600,000 budget. I will say something that I think is really important as a leader. A nonprofit at the end of the day is a corporation, and it's required to have cash flow, and it's required to have a balance sheet that is balanced. And so often I think we see, especially CBOs that are in the smaller end, we see very passionate, driven folks running them that have industry experience, but they lack the business accoutrement to be able to understand the background in finance. And I think that that is why so often, specifically here in Sacramento, we've seen this, many of them have fallen off over the years. We hire within because we believe in promoting those people who love what we do, right? But so often we need to look outside. And as Rhea said, look at the business folks that are out there that have that knowledge. It's easier to apply that business in a general sense to an organization than to take someone that has maybe specifics around running HIV or being an HIV mental health person and ask them to be a business person. So think the other way when you're looking at the future of your organization. The other thing I've seen too, and this isn't just HIV Community Direct, but I believe that all major leaders of organizations should think about turnover, right? Turnover of themselves, though. What is the future of their position? We get people that get in there and they'll stay for 10, 15, or 20 years, like the person that I took over from. And unfortunately, they had been there so long that they forgot to think about what was the viability of the organization in the future, and they ran out of steam. And so people often will ask me, well, how long will you stay at Sunburst? Well, I'm not exactly sure how long, but I know it won't be forever, because I think it's really important to bring a unique new experience into the organization, look around. And also, I think that there's so many of us that are working and doing incredible stuff that we put these blinders on and we focus on our own organization and we forget to look outside. And then we get into these siloed situations where we forget to support the people around us. So that collaboration and partnership is really important. But I think it's also our responsibility to shift within organizations as well. Take your experience and apply it somewhere else by possibly applying to a new job or taking on a new position in an organization. So I just think that's really an important thing that often is forgot about, and that we need to put to the higher end in our process.
I appreciate all of those. And I see your hand. Go ahead, Gabe.
Well, that was a mistake. I was more so just trying to clap for what Jake
claps,
said.
yes. And
But I would just say from a founder's perspective, we have to be extremely careful of founder syndrome. And to all my founders out there, let me tell you, the syndrome just doesn't eat them; it eats you. And so for me, I was very clear about 5-6 years ago that I didn't want to stay past a certain period, and I've already been cultivating and developing my successor, and in a business-oriented fashion. And so, I mean, I would encourage any founders that there is an other side. And there is a role that we as founders have after 10, 15, whatever, 20, 25 years. There's a role you have. You're just not taking up that seat. There's roles that exist for you, that you're not taking up the mantle on these other roles that really society needs you for. And so you cannot begin to take up those roles and those tasks until you liberate yourself from the seed that you birthed. And so I would just encourage any founder to see that there's so much more on the other side of what we started.
That's amazing. And I actually wanted to just note that we have time. We have 20 minutes left in this session, and we want to get to as many questions as we can. We want to hear from questions. I'm going to read a couple things from the chat. And I also want to, the next question that we're going to kind of approach is this idea of recruiting and supporting staff in this volatile services environment. I want to add a layer to that question so you can think about it for a second. The idea of how you continue to center your clients. And we've heard during this overall a symposium, that's important that we give and that we center clients in all ways, including through the workforce, right? Because and how can we create more opportunities for individuals to come into the workforce and to serve in roles that used to help them as clients. And so we'll talk about that kind of as another layer, recruiting and Gabe, you actually talked about kind of recruiting next step leadership. Jake, you talked about this running out of steam component. So like there's many different aspects of how to approach that question. But I wanted to just a couple comments from the chat. And I'm just gonna let me see. There's a comment from Yemeni that says, interesting that many examples of self-sustaining program models come from the violence prevention space. And that's important to note. And actually, it's interesting also that a lot of that our healthcare system kind of that we developed in HIV we blew out this idea of, or blew up the idea of consumer focused models in healthcare. So a lot of things that we learned from in various movements. And so Yamini, you can even say more about that if you'd like to. So we'll cue you up for the future here. But I'm also reading a comment from Kevin Sitter. I continue to advocate that our funders provide some of our grant funds up front. And some of our funders at the state actually our barriers from the state, from the federal government, are also barriers for that. So we've seen examples of organizations that may not have survived their ability to implement a grant after successfully getting that grant because they just couldn't front the money. And so, and Ray, I'm seeing your comment as well. So with those comments read, and also there was a comment too, Gabe, just about the environment in the Inland Empire and how difficult it is to develop services in the context of a very conservative area. So going back to this idea of centering clients as you design your programs for sustainability, because not only are our staff members are concerned about their work, but the people who we serve are also concerned about programs that serve them. So if you could talk about that, maybe add a layer to maybe creating opportunities for staff to come into the organization, if you have examples of how that has happened in your workforce development. Ray, go ahead.
Yeah, I would love to answer that question. So one of the things that I knew early on when I first joined the organization was that the way that we do the work is pretty different from I had previously worked at a federally qualified health center, and peer navigation, it wasn't really a best practice yet, right? So there was a pilot program that was actually launched at the state level to local jurisdictions to pilot peer navigation programs and also like prevention navigators. And Christie's Place was one of the places where I did research when we received that funding and I was still at the clinic. Their program was really unique in that there's like a foundational training that we use to train people on how to become a peer. And these are folks with lived experience, which, as we know, if we have peers employed within our organization, there's a lot of skills building that needs to happen. Some of them may not have had professional jobs before. And so really taking the time, not just to develop those professional skills, but also to really help them understand the issue around boundaries, around vicarious trauma, secondary trauma, those things that they may experience out in the field that they may not be prepared for. And I love that we had a training that really focused on that and spent time and practiced those skills with the women that went through it. And what I've found is that our peers who go through those types of trainings are better informed. They create those boundaries a lot easier than folks who maybe just were kind of dropped into that role. And then also just providing that mentorship. So having women that have been doing the work successfully for a long period of time, giving them the opportunities to supervise, to allow people to shadow them in their experiences and talking through situations with newer peer navigators has been incredibly helpful, and centering that client, that community in all of our work. We've expanded some of the work that we've done with peers over the last several years to include a paid internship opportunity for folks in the field who are already doing this work, but just need the backing and the resources to continue growing their programming. And like I had mentioned, the mentorship that happens not just in San Diego anymore, but now we're doing it regionally, where we have folks from San Diego coming to train folks in LA and hoping to expand into other areas as well. So just really sharing that wealth of information and experience and allowing a safe place for people with lived experience to ask and practice those skills.
Thank you, Rhea.
Yeah.
Anybody else want to address that on the panel?
Sure. I mean, for me, it's really about mission alignment and not just looking at resumes, right? I really believe that if we have purpose-driven recruitment, that we're going to get folks into our organization that believe in the purpose of what we're doing, not just getting a paycheck. And part of that is looking at our clients, the folks that we serve, our community. Whenever I think about expansion of a position, I immediately start thinking about the clients of ours that are looking to re-enter the workforce, and encourage them to apply. We do panel interviews here at Sunburst Projects, and my team, which I always sit in on the panels, always say, how come we don't ask questions about their work history, but more about who they are and what their purpose is in life? And that's because for me, that's incredibly important that I know that. Being a mental health provider, I compete against a lot of hospital systems. And unfortunately, as a grant-funded organization, I can't always pay at the same rate as they can. So when I post a position for a mental health, I have a pretty well-written statement that is at the very top of those postings that explains that I'm really looking for someone who wants to see the impact of their work, that they want to create, long-term relationships with those that they're working with to help them deal with a crisis, whether it be related to their diagnosis or other things in their life, but that their opportunity here versus working in a hospital, which is more of a crisis center, is to have those long-term relationships. And I do believe that there are folks that kind of fall into those two categories. And then I think once we get folks into our staff and in our organization working, it's about transparency, growth, and flexibility. I worked for someone early on in my career who had a sign on his desk that said "No secrets," and I followed that through my whole career. And I now have a sign on my desk that says "No secrets," and that's truly about telling the transparency of the organization. As long as I can tell you without breaking the law, I think it's your right as an employee to understand where are we financially. Oftentimes when we have board of directors who are running organizations, the financial health and wellness of the organization gets kind of delivered there, and it doesn't often go back to the staff. So I have those heart-to-heart conversations with the folks that work for me about where we're at and how we're doing financially, because I think it's important. It takes away the worry. Do I have a job for the long term? I also love including as many of my staff in our grant writing process. When you win a grant and they can take some responsibility for that, I think it also brings value into the work that they're doing. And so I think that's really important. So in a landscape that's constantly moving, especially in public health and where we're at now, that transparency I think is so much more important than it ever has been before. Bring people along with you. Don't leave them in the dark.
Thank you, Jake, for that. And I'm doing multiple things now, so I'd really like to concentrate on exactly what you're all saying, but I don't have the luxury of doing that. So I'm going to watch the recording and realize and so this has been a gift, everything that I've been able to pay attention to. Gabe, over to you, the same question about sort of centering clients and this idea also of bringing clients into the organization as staff and leaders.
Yeah, I mean, many of my staff are or could be clients or would be clients, if they didn't have this job. And, we have to remember that we are recruiting from a population that we are espousing is traumatized. So we are saying that these are traumatized communities, these are very rough circumstances our clients come from, and we have to understand that they bring that temperament into the workplace. And so for me, recruitment is everything. Where we recruit is priority one. And for me, I try to get my hiring managers to not just look at, like Jake said, the resume, but for us, it's really more about alignment. It's really about temperament and really an agreement with management style. Now, I want to underline that last piece, and I want everybody to write it down. Alignment with management style. And that's because in our world as nonprofits, we got 8 different ways that we like to run a business. There's some nonprofits that don't have an ED. They come together to just all equally collaborate. There's some people that have co-executive director models. There's some people who have heavy CEO models, that have heavy board managed models, that have models in which it's highly decentralized, highly centralized. And so we just need to be clear about that the kind of model you have. If you are a bit of a controlling type A CEO, I'm not as much anymore. We've come down a lot in the years. But if you are that way, then don't recruit a staff person who you know comes from the Liberation Flower Power children. Like, don't do that. They are not going to like your management style. They are not going to like the way you do business. You have to be clear about who you want to be as a leader, who you want your organization to be seen in terms of its leadership, and then recruiting people who are aligned with the sort of style that you want to build your business. Working at Apple is very different than working at Tesla, which is very different than working for the Koch brothers, for instance. 3 completely different philosophies, morals, everything. And so you need to be clear about the identity of your organization. There's 4 Ps that I say that I've learned in the 18 years that has been tools to help me recruit and keep some of my best talent, has been pay, peace, prospects, and purpose. So those are the 4 things I have found. Is that pay, number one. Pay is very important. They want to get paid at close to the 50 to 60% of not only your lateral agencies, but others. Peace, there is an expectation that there is some degree of enjoyment with coming to my job. Prospects, I know where I'm going. I know there's a future for me here. I'm going to rise up. There's a place for me to rise up. And then purpose. Do I actually feel like what we do here is something that I care about? And like, we have to constantly as leaders manage those 4 elements, and they sometimes collide against each other, as Rhea and Jake pointed out, with budget constraints. Oftentimes creating and animating those experiences require money, right? And so if we don't have it, I can't always create the experience that makes the work experience always feel fluffy. And I think we have to prepare no, I say that intentionally because there are some staff people who come in expecting fluffiness. And this is a grit organization. This is like military SWAT team, SEAL team force. We're dealing with very complicated, rough issues. And so you have to have the temperament to deal with ICE raids, to deal with attacks from Planned Parenthood and having your building attacked and blown up. Those kinds of things you have to have the temperament for to do this kind of work. And we as leaders have to recruit those with that level of grit and commitment.
Thank you for bringing that into the room, Gabe, because we had some comments too over the course of this symposium about just how awful and bad the situation has gotten for the work and the people that connect to the work and to connect to the organization. So we don't want to pretend that the policy and funding environment hasn't eroded. And these are examples of the things that we have to prepare to do, right, in a different environment. And some of that environment actually hasn't changed very much. People have been doing clinic defense for reproductive right organizations forever and have been threatened, et cetera. So Yamini, I wanted you to come off mute if you can, because I think one of the things your comment is interesting, because actually I had a past boss that came from the violence prevention space. And I think some of the background of your comment might be that because of the fact that violence prevention spaces kind of deal with trauma, that bringing that into management has been part of the success of maybe some of these organizations. But I'm wondering if you can take yourself off mute and give more context to your comment. If you'd like to, you don't have to. Or you could just provide it. Oh, let's see if they may not be here anymore. So we can imagine what that might be. But I'll answer part of that in that we had a session recently within CDPH talking about trauma-informed management and how that was critical to sort of improving the experience of the space for employees, just kind of recognizing what that communication style meant, what it means to actually be a trauma-informed leader. So anybody can address that, but we're coming down to the last 5 minutes. So I did want to do two things. Maybe so there's a question that we have about sharing some hope, warning, or love, or support, or anything you want to as kind of last comments to this session. And maybe you could kind of weave in some of the ways that funders can be better, if you have any suggestions for that as well. But if you can just focus on some last words of hope, warning, love, support, or anything you want to HIV, STI, hepatitis C organizations like yours, or that want to be like yours, that are part of the audience today.
I can
Go ahead,
start if you all don't mind. Yeah. So I think my feelings around hope is that sometimes we have to create that hope for our staff, for our clients, for our community. And part of that, I think, is just being there and being available and allowing them to come and experience joy, even in small, small amounts, right? Maybe it's just a cup of coffee and a conversation with somebody who they haven't seen in a while. Or maybe they just want to come into air conditioning when it's really hot outside and charge their phones. Like those are small requests that a lot of the folks who we serve have. And so we're in a fortunate capacity or a fortunate position to be able to provide those small things without making it so difficult. And I think that's part of being trauma informed, right? Is really understanding that it's those small things that make a difference in somebody's day and possibly in someone's life. So I would just encourage us to continue allowing ourselves to be humble and open enough to let those things happen. And, you know, there's rules that all of our organizations have to abide by, but at the same time, like, let's not make it harder for folks who are already struggling. So that's my one advice for hope. And I will also say for folks who are really interested in leading an organization, one of the biggest lessons that I've learned is to create space and have colleagues, a community around you, find ways to connect with other nonprofit leaders, even if they're not within your industry, they know what you're going through. And so having that that neighborly kind of teamwork around you and being able to be, you know, talk about ideas openly with one another has been incredibly important during my time at Christie's Place, and one that there's an organization that I give back to and offer executive coaching as part of their team. And they only work with nonprofit leaders at very low cost. So finding places like that still fulfill you as a leader and you're able to give back, I think that's so important to folks who are looking to do this type of work.
Thank you, Ray. I feel the hope rising and also the fact that there's some attainable steps to kind of creating that hope. Thank you for that response. Jake, over to you.
Yeah, I think in a world of no's, I try to be a leader that says yes. And I think that's hope for everyone, for your clients, your donors, your funders, your staff, and the community that we support. I've often told my staff here that our position or our place in this, especially when it comes to funding, is to be not a gatekeeper, but to be a conduit to get it into the hands of the folks that need it, whether it be food cards or gas cards or housing or just assistance with mental health. We so often grab a hold of something and we want to keep it. And I think that is not our responsibility. It's actually to move it forward. So, yeah, just saying yes can make the major difference in a person's day or in their experience. I was just thinking, you know, as Ray was talking, and you know, I've talked quite a bit about collaboration, but invite every person you can into your organization to tour and see what you do. I invite every elected official from federal to state to city to come have a private tour at Sunburst every year. Even if I know they support us every time they can, I still want to give them that 20 minutes of my time because I never know what's going to come back from that. And I think some of the most powerful partnerships and collaborations I've made have been through my elected officials at a local and federal level. We do a really cool thing here at Sunburst called Shining a Light, and we reach out to one of our friends here at Sunburst who has a pretty large space in their house, and it moves around. And we reach out and we find the names of folks in our communities who may be philanthropists that aren't related to the HIV community or even the public health community. And we invite them for what we call a fireside chat, which is essentially 30 minutes of me kind of talking about what we do at Sunburst and really bringing out the importance that HIV is still spreading. And so many of these folks, after the end of the talk, will say, I had no idea. And part of that is because the media in this world has really kind of turned since we've had antiretrovirals that are allowing people to live long lives and are focused on other diseases. And we need to shout as loud as we can to as many people that HIV is still spreading. So it's not about asking for money in those events. It's just about informing. And ironically, when we do our year-end annual plea, most of those people that come to that event make a donation to Sunburst projects that never did before. So if there's one thing you can take away from, I think, what we've all said here, is just inform as many people as you can. Network, build, and collaborate. And I think that in the end, you'll find your organization to be incredibly stronger than it was before you started.
Wonderful. Thank you, Jake. And I had the honor of actually sitting in one of your counseling rooms at where a client sits as part of the tour that you provided to the CDC when they came to town in Sacramento. So thank you for that. It gives you that perspective. Gabriel, go ahead. Over to you.
Yeah. For any of my historians or political scientists, justice is a pendulum. You know, Mussolini, Stalin, Hitler, all of the many horrible figures in times, they had a season. There was a season. And justice has always been a pendulum. And it for certainly will swing back the other direction. And I think hope in the way that we've been pursuing it is sort of this wishful pie in the sky. And I think we need to approach it more like faith, the confirmation and knowing without evidence that that is how justice works. Justice swings back. The question is, what are you doing right now while we are in the reverse pendulum? And when we come back, are you going to be ready for the moment that is going to be needed for the architects, the builders, the reconstruction of our world? There will need to be us ready. So this is your Super Bowl. Don't feel any despair in terms of this is going to be forever. This is our Super Bowl. This is the moment we were made for. And what I would say to government, more specifically as the funder, that was your second question, the government is getting in its way more so than it even acknowledges. And oftentimes it is your own regulatory policies that completely take the wind out of everything that we talked about in these moments. So really be clear, government agencies, that if you really do think we are in a state of emergency, if you really do think that agencies are failing, if this is true, you're not just saying it, you really believe that, then for every new policy you create, you need to get rid of two. So for every new regulation, get rid of two of them. And I think if you can really have the courage, innovation, and if you can truly be out of the box thinkers like that, then I think you would do a great deal to strengthen the nonprofit network if you could deregulate a lot of the unnecessary repetitive regulation that we have to go through that makes our doing our business very expensive. So that would be my advice to the funders.
Thank you so much, Gabe, for that. And all of you, we're at time. And so expressing appreciation for the thoughtful comments from the panelists and from people that provided input to the chat. You also posed some big questions and challenges to this environment, but one of the things that I heard you say is connect in support. And so this is part of that supportive network. And I actually had some places where it actually that made me feel very hopeful and almost ready to run to the next step of implementation. So I just want to thank you so much for the time that you spent with us today. We know that you have a million things to do, and this is part of how you spent your day. We're very grateful for that. And with that, we'll go to break. So thank you all for the time that you spent with us today.
Thanks for having us.
Thanks for having.
Great. Next slide for the break.
Yep, I'll share in just a sec. I want to adjust the time. Just a minute.
No problem. And as we prepare the slide for break, we are currently on a break until 2:45. Great. We'll see you back at 2:45, everyone. Hi, all. We just wanted to announce that we're going to be taking a longer break. So we hope that you use the next 15 minutes just to get a snack, rest a little bit, and we'll be back at 3 o'clock.
see me and hear me?
Yes, thank you.
Okay, great.
Great. So we're going to restart this session. Welcome back, everybody. Dr. Erica Pan, welcome. So we're going to provide a few words of introduction and welcome and introduce our next speaker. Thanks so much, and I hope that extra time allowed folks to take a little bit of a rest during that longer break. So it is my honor to introduce Dr. Erica Pan, who's the director of the California Department of Public Health, as well as our public health officer. Dr. Erica Pan serves as director and state public health officer for California, the California Department of Public Health, a role she assumed on February 1st, 2025. As CDPH director, Dr. Pan strives to embody and promote the values of dignity, equity, and compassion and humility. She works with collaborative partnerships to communicate, empower communities and institutions to transform policies and systems to include a health in all policies approach, acknowledging that addressing the social determinants of health are fundamental to achieving healthy communities with thriving families and individuals. As California's public health officer, Dr. Pan exercises leadership and legal authority to protect health and prevent disease. We're so pleased to have you with us, Dr. Pan. We know that you're coming from several different meetings before coming here, so we'll just turn the mic over to you for your presentation.
Great. Thank you so much, Leroy, and really nice to be here with all of you. I think I last got to see many of you at the HIV STD controllers meeting earlier this year. But yeah, really happy to help close you all out for this 4th annual Ending the Syndemic Symposium. I want to start by thanking our HIV, STI, and Hep C partners and the Syndemic Symposium Planning Committee who invited me to speak today and who helped plan this meeting. It's always a lot of work, whether in person or virtual and or hybrid. All of it is a ton of coordination and organizing. So really huge thanks to all of you that took time to plan and those of you that took time to be together. And this is really important as you all step back for a moment. I think we all always have, so many things on our to-do list and things to do. And sometimes those urgent things keep us from doing the important work of meeting together and convening and brainstorming and helping us prepare for the work ahead. So it's, hopefully it goes without saying, but I know this is a really challenging time and it has never been more critical for you to be good at what you do here in California. Together, all of us and all of you help foster a healthier California. And honestly, we are really being looked at across the nation for our ongoing leadership in public health and certainly in this space related to HIV, STIs, and Hep C. And on that note, again, we need to name that things are incredibly difficult right now for public health work. And we continue to have new barriers or issues thrown our way. And so we'll be touching on some of that in my remarks in this talk. But I also invite you to ask questions about this at the end when we have Q&A. And I want to highlight some of the great work and great successes that all of you are doing in this space. Next slide. So today we're going to, again, talk about celebrating the amazing work that all of you do, vital to a healthy California. And you are all serving together some of the most vulnerable communities here in our state. And there's also important social determinants of health that are at play across the conditions that you work with. And we are proud of the commitment of our programs to center race, ethnicity, sexual orientation, and gender identity and community engagement in all of the work we do. We're also going to talk about some of the great successes and how public health has worked and show you the impact that you have had on people's lives. We're beginning to see the fruits of all of that hard work and turning the tide on many of the conditions you all work with and work to prevent or decrease the impacts of. And all of our approach in public health means needing a data-driven and evidence-based strategy. And again, this is where all of you in California continue to demonstrate excellence and will need to continue to be leaders in this space during this unprecedented time. And we have to keep thinking innovatively. I'm going to talk a little bit later too about reimagining public health and how we're all needing to do that in the environment we're in and making the case how critical public health is. And we'll also talk a little bit more about the value of investing and the return on investment in public health. Finally, we will definitely talk a little bit more about how we continue to navigate these unprecedented and turbulent, uncertain times. Many of us and the communities we serve and the people we love are under an immense amount of stress and uncertainty. And we can meet these challenges if we can be strategic in our approach, and more importantly, work together and strengthen our partnerships and take care of each other. Californians need you to continue your passion, your dedication, in alignment with all of your values. Next slide. Oh, and in the end, we'll be doing some question and answers, and where we get to hear from you. And on this slide, actually, we are going to start with some polls. So we want to take a Zoom poll of people here on the webinar, and we have a few different questions here. So the first one is, have you integrated HIV, STI, and Hep C work in your clinic, community-based organization, or local health department? And as you're seeing, hopefully on your screen, you can answer yes, no, or you're not sure, I don't know. And the second question is, could you use some help, collaboration, and partnership in this work? And then our last question is, do you think your experiences integrating services could help other jurisdictions?
We're developing the poll responses right now, Dr. Pon. Dr. Pon, as you're thinking about reacting to the responses, we'll just say that I know that you've been asking this question in a lot of forums. So this is one more forum, and this is an opportunity to talk to a place where we have physicians, we have community-based organizations, we have people with lived experience, kind of all orienting on this integrated HIV, STI, hepatitis C work. So we're so pleased that you're here.
Yeah, no, I wish we could all be together in person too, but it's really great to hear from all of your different organizations across the spectrum of the way we work together. And look forward to seeing some of these poll results.
Great. So
let's see. And I forget, are we gonna show poll results now?
We certainly are, yeah.
Okay, great. Oh, here we go. All right, so let's see. As far as RT integrating, almost 90% of you have already integrated HIV, STI, and Hep C work in your organization. That is great. That is really great to hear. And almost 2/3 of you could use some help in collaboration and partnership in this work. So that's exactly why we're all here, and why you can hopefully continue to have heard a lot of shared lessons learned and other ways you can reach out to each other and help each other and strengthen those partnerships. And then a larger proportion in that area are not sure. So, but again, hopefully you'll have more resources that you can look to after this symposium. And then this third one, do you think your experiences integrating services could help other jurisdictions? And almost 2/3 of you, 60% of you also have things you have done that you think could help others. So definitely hope you can all continue to share that. And then a larger proportion of you in this one didn't know or don't know. But I hope this also just demonstrates to all of you the value, again, of having these collaborative spaces and collaborative symposiums to work together. Great. So why don't we go ahead and go to the next slide? So really want to highlight here again, just using the numbers and show how important the work you all do is. This was an AMFAR analysis, and it shows when there was increased funding to the CDC's division of HIV prevention, that was associated with a nearly 20% reduction in new HIV infections across the US between 2010 and 2022. When ending the HIV epidemic in the US by 2030 was made a priority, new infections decreased by almost a fifth. As you all also know, federal government is now proposing drastic cuts in funding for the CDC's division of HIV prevention, and subsequently all of those grants that come out to state and local use. Not only would we lose momentum in driving down HIV cases, but the nation's epidemic would become considerably worse. So this is where it's really important for all of you, actually, especially those of you that are the closest to serving your HIV community or people who are at risk, and also have your local data to really share impacts. I'm really learning in my role that It's always good to show the data and also to really tell stories and really talk about the impacts and the people the lives you're touching, and being able to convey that to some of the policymakers and decision makers. Let's go to the next slide. Also wanted to just highlight, I hope by now you're all very familiar with the California Department of Public Health's Office of AIDS and Sexually Transmitted Disease Control Branch's joint work to develop the first integrated HIV, Hep C, and STI strategic plan for California. And as you likely also know, the accompanying implementation blueprint. And there are many activities there that address the outlined strategic directions. This plan was an incredible accomplishment. It reflects diverse voices from our CDPH department, other state agencies, local health departments, community-based organizations, and people with lived experience. In this plan, you'll find a picture of what we hope the HIV, Hep C, and STI landscape in California would look like in the future, and some ideas for how to create it. As we address HIV and Hep C and STIs together, it's very powerful because these issues affect many of the same people and communities. And all of these strategies are organized across 6 social determinants of health. You can see here racial equity, housing first. There's been a lot of work in this space across the state, health access for all, mental health and substance use, economic justice, and a stigma-free environment are some of the highlights of how we've been organizing these strategies. This builds on many years of work of people affected by HIV, Hep C, and STIs, as well as public health healthcare providers and other partners across the state. In order to end this syndemic, it's going to require all of us being bold and reflective and centering the communities that have frequently been neglected and mistreated. This plan and the blueprint are organized across, as just mentioned, the social determinants of health, and you can get links to all of these plan documents in the slides and resources. Next slide. So again, I know we're speaking to all of you that know and live this, but just to highlight who are our priority populations that HIV, Hep C, and STIs disproportionately impact. It's our most vulnerable. It's people who are unhoused, people who use drugs, people who are incarcerated, men who have sex with men, transgender women, youth and young adults, and our Black, African American, Latino, and Indigenous people are all disproportionately impacted. And over the course of the last few days during your symposium, we know there have been a lot of great presentations with data to describe these factors. And you all came into this meeting as experts already. But we want to end with a restatement of our priority populations and really, again, elevate, and again, more important than ever, to be elevating and prioritizing these important populations as part of our Ending the Epidemic strategic plan. It's really important for us to recognize and name populations that are disproportionately impacted so we can focus our efforts. It's such a fundamental part of our work in public health to recognize where the highest disease burden is, and really importantly, our job in public health is to help identify root causes and work to address those disparities. And we see so often that these root causes are causes for all kinds of different health problems. So increasingly, we're doing a better job, not only naming who the communities are that are most impacted, but engaging and empowering communities, those with lived experience, and working with them to develop solutions and what their needs are rather than to or for them. And of course, the richness of our diverse state is rooted in our inclusion and celebration of different perspectives and the value we place on both the individual and collective experience. That includes really customizing our approaches and focusing resources on populations that bear a greater burden of diseases we're working to prevent. So let's go to the next slide to look at some examples of some really impactful syndemic work. So street medicine effectively delivers mobile primary care and other supportive services to unhoused communities and meeting people where they are. This is the other beauty of public health and collaboration with other healthcare providers, really getting out of sort of brick and mortar clinics and again, bringing services to meet people where they are. And similarly, Take Me Home is person-centered self-testing. This is really putting that screening into the hands of clients, getting to them in their homes, and it's been expanded to all California counties. The Aura Quick testing has been in all jurisdictions in California as for the last 2.5 years, actually. And then, of course, being able to integrate out of care lists for people co-infected with HIV and Hep C as we've improved our data systems and our service coordination, we can get more of these out of care less coordinated, expanding HIV and syphilis screening and treatment and PrEP access in pregnancy. And of course, ED screening for STI, HIV, and Hep C are all really important examples of great work that's happening that all of you are delivering to address this endemic. Next slide. And just again, some really nice highlights, and there are so many more, but just some highlights. And I know many, you talked about this on day one as well, but elevating that we have quite a toolbox of strategies to address all of these diseases. And as a state and in each jurisdiction in California, there have been thousands of people doing incredible work towards ending this endemic. Everything from the implementation of treatments that maintain people's health if they're living with HIV, to the uptake of HIV PEP and PrEP, and now DoxyPEP, which I think we're going to talk about in a moment as well. But the work that we've done has been vital and continues again to be a model for this kind of work across the nation. During this meeting, you learned from each other about successful strategies across all these topics, implementation issues and operational issues, and you dove into details and shared your lessons learned and your challenges. So take these lessons with you and all of this shared information so that we can each make our incremental steps to decrease barriers and to services and increase uptake of these really important and powerful tools. Next slide. Some other highlights we really wanted to make sure to mention are our partnership with Peregrine Media, who has helped us integrate integrated sexual health campaigns to drive sexual health testing and vaccination. So often we end up doing these in a very disease-specific way or categorically funding things separately. And this was really a great testament to integrating sexual health. And with this investment and push through social media, which is really how people are getting their information now, we've seen increases in HIV test orders through the Take Me Home program, linked to those ads, and we've tested thousands of people across California. So this integrated approach is really crucial to maintain as we move forward. And there will be links to these toolkits as well. And then as far as treatment as prevention. So again, I know all of you know this data well, but it's always really striking to be able to look at it visually. This chart shows HIV/AIDS diagnoses in red, new HIV/AIDS diagnoses per year in green, and all-cause deaths among people living with HIV in blue. The bars show all the persons living with HIV over time, and you can see the dramatic successes over time. In 1995, when HAART became widely available, you can see that the introduction of that highly effective treatment resulted not only in death from HIV in blue dropping dramatically, but also the new HIV and AIDS diagnosis per year also dropped. And then some other notes on this slide that we've been visited by a great loss and fear before, and we've come through to the other side with our collective efforts. When we first had this new emerging disease and we weren't sure, very early on what the cause was and how to treat it, how to prevent it, and look how far we have come. And we can continue to take on these challenges together. And we have new barriers to our work together, but we can be innovative together and we can continue to take care of our communities together. It's also, of course, striking just to, acknowledge that all the lives lost, but also really importantly in public health and all your great work, the lives you all have saved when you see these trends. All right, let's go to the next slide. So this is also just a really great graphic to show Dr. Stephanie Cohen's work in San Francisco when they presented this at CROI last year about the impacts of DoxyPEP on the community level rates of chlamydia and early syphilis in San Francisco County. As you can see, these data show these remarkable decreases in STIs have been climbing for decades. And so San Francisco led the way in November of 2022, and then we at CDPH issued recommendations soon after for doxy post-exposure prophylaxis statewide. That, combined with other investments in public health infrastructure, has started to show a turning of the tide in STIs statewide. Dr. Jacobson also presented more on that topic on the second day. And again, we'll have links to the sources and other resources for this. Next slide. We also just very grateful and very proud of the very rapid response to the first Clade-1B Mpox virus infection that was reported in November 2024. This was associated with travel to East Africa and identified in an emergency room in San Mateo County. and the very quick response of very astute clinicians and the STD controller and San Mateo County's entire team. And that collaboration across San Mateo with us at CDPH, the CDC, and Stanford University was really remarkable. And we all had been preparing for and talking about the potential for Clade 1 to enter the state, and we had a rapid response plan, and it was activated quickly for quick public health investigation, contact tracing, daily monitoring. And I know that our team has been working with all of you to look for, electronic lab reports coming in that might be related to the case. And there was ongoing communication across multiple public health agencies, not only across the country, but actually around the world. We had some calls with some of the other countries that were starting to see their first introductions of Clade 1b and trying to understand any other linkages. So it was a really, really great collaboration across the board. And really importantly too, there were no identified subsequent cases among any of the contacts. So this really showed another testament of public health, working quickly and containing and activating emergency preparedness and response as well for infectious diseases. So really, really great work to all of the teams that were involved in this. Next slide. I also, especially increasingly in my current role, want to make sure that we as a public health community really find and share information about the return on investment for public health programs. Even Ben Franklin said many, many, many years ago, an ounce of prevention is worth a pound of cure. But that's not what happens in this country. We spend less than 2 to 3% of our healthcare dollars on prevention. So we have to really continue to beat the drum of showing that return on investment and being able to communicate it in ways that people will hear and listen to as we think about scarce resources and how we invest them. Public health savings of millions now can lead to billions in future healthcare costs. It also, of course, amplifies lost productivity when people are ill, emergency response spending. There's been estimates about a bird flu pandemic could cost exponentially more than savings from cutting the staff in the bird flu response program. So we've seen these returns on investments in public health over and over again, and all of our efforts require staff and resources. For opioid crisis response efforts, for example, every $1 invested in overdose prevention, $4 is saved in healthcare and criminal justice costs. The Vaccines for Children program prevents 42,000 deaths annually and saves $10.50 for every dollar invested. That could be $2.2 trillion in taxpayer savings. There's community weight loss programs and mental health interventions. And this is just a really nice graphic from your local epidemiologist, really showing visually these important returns on investments. So I urge you to all continue to look for these kinds of examples, and specifically, within the syndemic HIV, Hep C, and STI field, and elevate those if you're seeing that on your local level or within your program. And let's continue to tell that story together to continue to advocate for the important resources for the work that you all do. Next slide. So just again, really naming and acknowledging that we are in, really unprecedented times. It just seems that the last several months, there's just always a new surprise and things that to me seem more and more surreal. And this picture is depicting like when people were asking me how I was feeling about my new position, I would describe, well, I feel like I'm trying to captain a boat that's going into uncharted, turbulent waters. And there's people are trying to dismantle the hull. But what I continue to be incredibly grateful for is such an amazing crew. We have an amazing team at the California Department of Public Health. We have amazing partners at the local health department level. We all it's an incredible public health system in California. And actually, a quick fun little tidbit from this week. Our governor was actually on Stephen Colbert this week, which you may or may not have heard, but he actually bragged about the public health system in California and how we have the best and the brightest. And we have, again, this amazing crew. So I really am incredibly grateful for that. And I think that is how we are going to keep moving forward in these uncertain times, by really relying on each other, taking care of each other, and being innovative. And we will get through this storm. We've been through other storms. Next slide. So we're really excited to share as far as, good news that we want to share. We have finally gotten approval for our new division of HIV, Hep C, and STIs. So it's gone through all of the sort of approvals at all levels in our state organization. So we are going to, and all of our staff have been convening to understand the work of each program as well during all of this, but it has been approved. So the first step, of course, is creating this new division. So there will be a new position who will be a division leader over the HIV, Hep C, and STIs division, and that will then be overseeing the Office of AIDS and STD Control Branch in their current state. So it is kind of, again, this lift and shift. And then there will be a multi-phase approach after that that will be thoughtful and intentional as a steady pace, planning led by staff work groups to kind of over time develop that true integration. So we're going to begin the process very, very soon of posting, interviewing for, and hiring the division chief. And once that is onboarded, we can start this process further as far as integration. So we know it's been a long time coming. I think, anyway, I was really excited to hear this myself too, as the prior CID deputy director, to see this great landmark. And we anticipate this means you won't see as many immediate changes or impacts to existing contracts or grants. But we are excited that this will help us, again, in this really challenging time, think about how do we reimagine how we're doing things, how do we use our resources more effectively and more together, and more changes will unfold as that planning occurs. I think it's also interesting, as you likely know, we're hearing that there will be consolidating funding for infectious diseases and like across viral hepatitis, STIs, and TB programs and opioids into one grant program. So we haven't seen yet how that's going to evolve and if that's going to evolve from the federal level, but some of this integration at the state level will hopefully help that transition a bit as well. Next slide. I also just wanted to share, just a sort of at a broader level, really exciting, and this also got mentioned. Again, anyway, it's so fun to have little random sort of places that are not typically where public health gets promoted. But this Public Health for All, this new law, got highlighted the other night on Stephen Colbert as well. But last week, we updated a state law to ensure that Californians can have access to vaccines, regardless of what happens, as we have worries about compromise of the Advisory Committee on Immunization Practices. And we've also created this West Coast Health Alliance together. And we, part of that is really showing the entire community, the people that live and work here and in our West Coast states, that we want to share data and evidence to people to make healthy choices. We want to continue to provide science-based recommendations, and we're here to protect our communities, and we're going to do that together. We really want sort of our states and others across the country to know there's a very strong community that still stands strong behind a lot of long-standing, important scientific and medical advances, and we don't want to lose ground on those. So the other thing for all of you to know is, certainly some of the urgency around this was being concerned about the Advisory Committee on Immunization Practices and Immunizations. But the other thing that has been at least verbally mentioned as something that could get dismantled, and that we certainly all have concerns about, is the U.S. Preventive Services Task Force. So what this new law in California does is it locks in any baseline recommendations as of January 1st. And then if there are changes at the federal level to that task force, or if they remove recommendations that health insurers or others are tied to, we can issue updates as needed so that California regulated health plans are required to cover, if it's ACIP, the immunizations, but really importantly, any other screening services that are in that USPSTF, if that does change. And again, there's been some threats to that. So we wanted to plan in advance and have this way that we could do that. There's also some liability protection to providers who can administer vaccines based on our state recommendations, and also making sure that like pharmacy and other allied health professionals that can provide vaccinations can do so based on these recommendations, and not having to change that if there's changes to the federal recommendations. So we're super proud of this, and I think it's a really good demonstration of how we are standing strong in our state for what we believe in, for our values for access and coverage. So stay tuned for other things that will continue to evolve in this space. Next slide. And with that, I think, I wanted to sort of share that is kind of how one of the ways we're reimagining public health. And so this is sort of, when we're imagining that ship and they're dismantling the hull, well, our crew can create a hovercraft. So, we don't know exactly how all that evolves and works, but I think some of these things I just mentioned are some examples of that. We're going to work together to figure out how to keep the ship moving. Again, we have an incredible crew. We have an innovative crew. We've gotten through hard times before, and we're going to come out with some innovation and some reimagining. And maybe there will be some other things we will maybe do even better for our communities when sort of given some of these challenges and barriers. So with that, I think that is my last slide. And I think we can shift to some Q&A. Yeah, thank you so much, everyone.
Great, thank you, Dr. Pon. And as we prepare for the Q&A, a couple of process comments. First of all, I'd like to introduce as discussants for this panel, Dr. Marissa Ramos, who is the California Department of Public Health, is the chief of the California Department of Public Health Office of AIDS, and also Dr. Phil Peters, who is the medical officer at the Office of AIDS at the California Department of Public Health as well. Dr. Pon, we also there's a couple of innovations for this particular symposium. We've actually made a really a great tool available in interpretation so that an individual can go and choose their language in the bottom and the Zoom controls. And we have participants that are listening in Spanish and prefer to speak questions in Spanish, so people may be able to do that. And if you would go down and choose the translation button, you'd be able to hear those questions repeated in English if that's your preferred language. So just a comment for the panelists. And we do have some questions that were posed as part of the preparation for this panel, and we have also some questions in the chat. So we once again invite those of you that are here to hear this dialogue and Q&A. And also one more aspect of this panel is that we've enabled the ability for participants to ask anonymous questions, because this is a difficult time, both policy and funding wise, and people may be more comfortable asking questions anonymously. We've also said, kind of as a guideline for this symposium, is that we don't necessarily have the answer to all questions. And some of the questions that we posed are big questions that we're going to be answering in an ongoing way. So we invite panelists to approach the answers to questions if they have, or the next steps to answering questions. But some of the questions may have to be part of our ongoing work together to answer. So so our first question is related to preserving essential programs. You outlined, Dr. Pon, so many ways that public health provides, and I was wondering if we can go to just the panelists alone. There you go. So many ways that we're being effective and we're creating an impact in California. It's being recognized at many levels, and it's being recognized across the country. There are folks that are part of the symposium and part of the field that have been submitting concerns about continuing to preserve essential programs, particularly for the priorities that we set. You held up that one slide that had our listed priority populations, and one of the participants in our symposium asked about how do we continue to prioritize transgender women, for example, during this shift in policy. And so we'll start off with that, preserving essential services, and then particularly for priority populations like transgender women.
Yeah, I will take a stab and then we can try to bring more information back. And I see kind of another related question about reproductive health care, and it was that, and I will admit, I do think in AB 144, in addition to what was protected around vaccine access and coverage, there were definitely parameters that had to do with reproductive healthcare access and gender affirming care. I'm less attuned with the details. I don't know if anyone else on the panel has more information, but we can certainly get back to it. But it has remained a state priority. Is kind of one of the bottom lines. I do know the records. I don't know the details, but
great. we also want to just follow up, but that on day 2, we had a special breakout session that was entitled Supporting the Trans and Gender Diverse Workforce. And there were a lot of specific examples of how we continue to make that a priority and need to make that a priority, particularly as we develop the workforce that needs to look like the Syndemic in California. So we can, unless there's other comments, we can develop that question at a greater level. And of course, there are folks on our symposium that can take themselves or raise their hand and comment on that further. The next question is sort of you talked about this great news about integrating the Office of AIDS and the STD Control Branch, which is great because there are so many ways that we integrate our work already. And when we've been in the community, some of our community partners have said, we thought you were already integrated because of the way that you work in the field. Can you talk a little bit more about how they might see a difference in the way that that we at the state interact with them? They're either through as health departments that we interact with, or community-based organizations that we work with.
I may start, but then I might see if
Sure.
Dr. Ramos wants to add maybe some more thoughts, because I think he's been closer to it more recently. But I think initially, I don't think there's going to be much change, but I do think over time, there may be some ways to jointly communicate. But maybe I should just turn it over to Marissa and let her respond.
Great.
Okay. Hi, everyone. I'm Marissa Ramos. Like Dr. Pond said, at the first phase, you're not going to see as much of a difference. And like Leroy said, we've already been working together really closely. So over the couple, probably last 3 years, 4 years maybe, you've seen that most of our contracts already have it as a syndemic. And so you're going to continue seeing that the funds could be used for STI, HIV, or HCV, or harm reduction. So that will continue. Perhaps once we become one division, right now you see many contracts, and maybe one of the hopes to streamline some of that to make your life's a lot easier and less reporting, less invoices, and less administrative burden. Maybe they could be combined into one contract for the counties. I think that'll help out folks out there. It will also probably help to braid that funding a little bit better so that you could serve the clients on the ground easier by braiding the funding. And also, I think, we've been working really closely together on community outreach and everything else, the media campaigns we've been doing. So I think you've already seen that. So we have, even though we're in 2 separate places, I think over the years we have already started combining what we want to see what this new division is going to look like. And then I think, like I said before, I think we want to streamline services a lot better, contracts, how we provide those services for clients. I think it'll be a lot better as well once we get into one division. And like also like Dr. Pond said, during these times, you've already seen that this year the DIS workforce funding was terminated or discontinued, and we were able to fund those activities with our ADAP funding. So I think the other good thing is it's going to enable both our offices to be stronger together during these times. And so I think it'll be a benefit to also the local health jurisdictions and to the community-based organizations out in California. So I think that's it.
Thank you, Dr. Ramos. And actually, I think Dr. Peters also has a comment.
Oh, yeah, I just wanted to mention one thing, because it's hard to do on individual calls, but I think some of you, if you work in a local health department, but I think also for CBOs, sometimes when we have a meeting with you, there's a lot of people from CDPH who are joining the meeting. And that is, I think, a reflection of this integration process that we're really pulling everyone together. So if someone is having a conversation with a particular county or a particular CBO that's funded through CDPH, it's not unknown to other, other parts of our organization what's happening. And so I think in the individual meetings, sometimes it can seem like, well, there's a lot of people from CDPH here. What's going on? But that is really a reflection of us programmatically integrating our work. And I think you'll also start seeing as we, integrate as a division in an office, that'll streamline as well, that there'll just be some more natural efficiencies, and it won't need to be quite so many people when you're getting on a call with us. We've even started to term it sometimes that it's the CDPH horde that has joined the call. It's just there could be a bunch of us, but that's kind of what is going on, trying to keep everyone involved.
Right. No wrong door for CDPH folks. And actually, if you open a door for us, we will show up in many different forms, as indicative by the way that we all work together at the state at this point, and hopefully more in the future. There's a question that in the chat that I think we can contextualize a little bit with this question that we had submitted earlier. In preserving access to vital data. And so people have been concerned about, like, if we remove the ability for us to actually talk about the programs and people, or the people rather, that the data represent, that where will that story reside? Like, where can we be sure to have access to the diversity of the information that we need to actually describe the syndemic and to address it? And then there's somebody also that in the chat that talked about California's effort to create their own research funder under SB 829. I don't know if you might be able to address that, but talking about how we preserve this idea of data and then the research that we're able to do with that data.
Sure, I will start, and then certainly my co-panelists can add anything else. I think as far as data, we have already had sort of the concept of legacy data before all the federal changes in the past year. And we've been able to maintain it and talk about and collect data. And actually, as many of you know, we've been, spent some time still trying to really improve the way we collect SOGI data, for example, sexual orientation and gender identity. There's also a lot of efforts nationally with, both the Council of State and Territorial Epidemiologists and some academic partners on how to there's some archive data for things that had gone up and down on the CDC websites, but also, like, if we need moving forward to have some other ways to share data, nationally. So there's some good partners there, and I think some good mechanisms people are working on behind the scenes. Again, we plan to stand strong on, the populations we want to still know who we're serving. We want to be able to serve the people and understand who's disproportionately impacted. The other kind of update just to share about CDPH is that we do have a new chief data officer. We've never actually had this position before. So we now finally have a chief data officer. She literally just started like a couple weeks ago, but she her name is Rebecca Fisher. She worked actually in LA County. She's worked in the city of Berkeley. She also worked for the city of New York Health Department. Right. And then most recently came from the CDC, actually as a liaison to the data office there. So we're really exciting that also, someone else can really just focus on that cross-departmental role of coordinating our data, thinking about our data. And of course, top of mind right now is data privacy and sharing. And there are some things happening with some of our data systems to really look at making sure we have as many guardrails as possible on anything we submit federally. So a lot of work happening in this space. And again, I think the commitment to our values is probably the most underlying importance there to know. And then, I need to myself find out more about SB 829. I've gotten a few inquiries. We have not been involved. My understanding is very much sort of research oriented and with a huge sort of dollar amount. I think it's like $28 billion. And, given all the kind of deficits and cuts and other things, I'm not clear how that could happen. I do think we have an amazing resource in California as far as the existing academic institutions we already have, and even biotech and others. So more to come, I think, on that, but CDPH has not been as in the loop on that. We'll be intrigued as well. And it admittedly in this really challenging time where we need so much more resources for so many of the different parts of what we all do, and we're really focused on fighting for public health and preventive. We certainly work hand in hand with our research partners, but we've been very focused on preserving public health services and programs. But stay tuned. I think we'll all continue to learn on that as well.
Great, thank you. And we're coming down to time, so we'll sort of ask one question and then invite you to invite any of the panelists to just kind of mention from their perspective anything that they'd like to kind of at this point in the symposium, where we have talked about stigma-free services, economic justice, and housing first. So any integrative statement you'd like to make would be wonderful. But there's this idea of addressing and influencing healthier policies through the information that we can provide to a variety of stakeholders. So we're wondering if you have any advice about how to influence better policy, healthier policy for California.
Sure. I mean, I think I would reiterate some of what I alluded to in part of my remarks around it's about winning hearts and minds. So I think this combination of how do you tell the stories of the people you're serving and the impacts you've had, and show kind of returns on investment and or the numbers and the impacts and the data or the evidence behind. So, and that is we're actually really good at a lot of that evidence collection from public health, and then also being able to really communicate it in a way that all partners and audiences can really digest and understand, and asking people like, what do you want or need to know about the effectiveness of this program. So I think that's one big area. And I think in general, we're really, as part of our reimagining, and something I was thinking about even before things have escalated as far as gaps federally, but just the way people receive communication in general is different. And this is not necessarily the policymakers, but I think as far as the communities we serve, really trying to think more about, like, traditionally we've done a lot of outgoing communication, but maybe not as much coordinated incoming of like, how is that message landing? How can we make it better? What information do you want to know or need to know that will help you make healthy decisions? So I think there's a lot of that as well. I think that can inform across the board. I mean, I think a lot of us recognize that some of where we are now in the attitudes towards public health are very much maybe reflective of what we could have done better during the pandemic, as far as communication and trying to engage people earlier and or answer people's questions more effectively about why we were doing certain things. But yeah, it's a challenging time, but that's some of my advice. You asked something else, but I've already forgot what it was.
I think the question kind of like last advice related to hope, but I did want to actually, there's a couple of questions that you might be able to answer very quickly. So I'm just going to suggest that there was a question here to clarify the question related to, does Public Health for All initiatives extend protections to include accessibility to birth control alongside vaccines? So that you said something about that, but I'm wondering if you know the answer.
So there were definitely things in that same, it was a trailer bill, actually language, trailer bill to the budget that had a lot of CDPH's focus was on the vaccines. And then there were definitely other departments working on the reproductive care access, so access to birth control and gender affirming care as well.
Mm-hmm.
We from our department were less involved, but my understanding is there are protections. So I do need to actually myself understand that better too, so we can get back to people. And the other thing I think also related to, whether it's Hep C screening or other kind of screenings that are recommended by the U.S. Preventive Services Task Force is something that's built into that law. If that gets threatened, we have a mechanism to require and uphold recommendations in California related to other kind of preventive services.
Great, thank you so much. And we have a question here that is, with some of the initiatives that are with some of these initiatives, are there any plans to expand funding for emergency department testing or test to treat models with the new guidance to utilize EDs for test and treat? And if you don't know the answer to this, we can actually answer this asynchronously.
I don't know if
okay.
Marissa or Phil have any other information?
Right now, we don't have the information on how that program would continue. We have the funding right now until June 30th of 2026, and we are kind of gathering internally to see if there's a mechanism that would allow us to continue that program. But right now, we don't have that answer.
Great. So we are at time, and we are at the time also to thank you, Dr. Pon, for showing up to the symposium, providing some concluding remarks, some exciting information that helps us actually put that information in front of the right people. I think that you noted a statistic about the percentage that we spend on prevention, and so we'll we'll put that into the chat because that was one of the questions too. We need to spend more on prevention, of course, and I think that's kind of underlying some of your remarks as well. So thank you, thank you, thank you for the work that you do and the ways that you're advocating for the needs of California residents and their health, and of course, all of our partners here on this line today. So thank you so much for spending this time with us.
Yeah, thank you all for all that you do. It's really great to be able to help represent a lot of the great work that all of you do. So thanks for the invitation, and yeah, hang in there, everyone. We're in it together, strengthen numbers and partnerships. So thank you.
Great, thank you so much. So we're moving to closing. We have just a few minutes of the symposium left. If we can come up with show the last slide, or the last few slides rather. Dr. Pon, would you, while you're here, would you like to just say thank you to the folks on the line?
Oh, absolutely. Thanks to you, Leroy, for all of your coordination, your facilitation. So, thank you, thank you, thank you. And to Jessica Fraser-Williams and Kathy, Dr. Jacobson, Dr. Ramos, Dr. Peters. I know there's a much larger Syndemic Symposium Planning Committee. I want to thank Michelle Leachman, who actually has helped with a lot of the planning for the reorganization within CDPH, and also has been helping me just prepare for talks and slides and other things. And again, to all of you who are on the ground, really taking care of our communities and, even closer to it. I have to admit, sometimes I miss some of that around being more local or even the clinical care that I can't do anymore. So I really appreciate all of you that are really directly serving communities in different ways. And, we are all sort of one big community together, and we will get through this together. So yeah, huge thanks to everyone.
Wonderful, thank you so much. All right, next slide, please. And next slide. All right, now it's time for closing, and we have, and if we could highlight my colleagues, especially Felicia and Angie, on the screen with me as we provide a few comments, and we can also, Angie, Felicia, and Dr. Ramos.
I'll go ahead. Really quick, I just wanted to thank everyone for attending, and we hope that you enjoyed this symposium. It was a lot of fun putting it all together, a lot of work, but also a lot of fun. And we hope that you all got as much out of it as we did. And again, thank you all for who participated, who showed up, for the panel members, for our tech, everyone. So great job, and thank you so much.
Felicia, do you want to go?
Just to kind of reiterate Angie's message, thank you to everyone, everyone who was presented and participated in our conversation. I look forward to working with you all in the future, and I see most of you, and I noticed a lot of names from like the stakeholder calls. So very happy that you guys were able to join us.
Great. And we'll have some remarks from just a thank you from Dr. Ramos, and then we'll move to the evaluation slide. So don't go anywhere yet. We want you to fill out the evaluation.
Yeah, I'll go quick because I know people, it's almost 4 o'clock. But thank you. This was wonderful. Keep the comments coming. As I said at the first day, the whole symposium would not be the way it is if it wasn't for all of your comments. So please do not forget to do the evaluation. And again, thank you for all those emojis that keeps us going and your questions. And as always, if you think of a question that you weren't able to ask during this symposium, you could contact us and we could respond via email. So thank you and have a great Thursday. Give it over to Leroy.
Thank you so much, Dr. Ramos. Next slide, please. So this is our evaluation. Please scan it, or also we put the evaluation link in the chat. We really built a lot of the content from this symposium, from all the comments and helpful suggestions from last year's symposium as well. So feel free to add suggestions for things that we could do better ways to center the critical values and a wonderful people, the communities that we serve in our symposium. If there's something that we just didn't hit well, let us know. We want to do better next year. With great appreciation for all of the hard work that you did kind of attending the sessions, providing just an amazing set of connection to and personal stories, which amazing examples of leadership that are really present in the community and actually lifting us all up. It's the reason that we're here. And so thank you all. And we'll see you at other meetings, of course. So this is just one of the meetings that you're going to have today, I'm sure. We'll see you in the future. And then certainly we want to see you at the next symposium as well. Bye, everybody.
Bye all.